And so my job for today is to moderate it and
Yeah,
moderate and convene this whole program.
absolutely.
So I first of all like to thank IAIO for this opportunity through Dr. Aditya Sareen. So we will be having a webinar for around 3 hours, but we would have a good mix of talks as well as debate as well as
Yeah,
panel discussion. So
yeah.
the talks are by some
And
leading experts.
just a disclaimer that this is not a pharma-driven event. It is purely academic. So all the students, wherever they are, just share our links so that we can go live as soon as possible.
Yeah.
Over to you, Dr. Ashwin now.
Thank you, Dr. Aditya. So good evening, everybody. Good evening, and I'm very happy to host this webinar along with Dr. Aditya Sareen, who's a dear colleague, medical oncology colleague from Sir Gangaram Hospital. So myself, I just give you a brief introduction. I'm a urologist, uro-oncologist, and a robotic surgeon from Sir Gangaram Hospital, New Delhi. And this prostate cancer as a topic is very close to my heart. So I have done a lot of work in this, not only clinical work, some research work, and all of us would agree that the incidence and the prevalence of prostate cancer, as we know, even in India, in urban India, it's one of the very common malignancies being diagnosed. And I'm sure our faculty from the UK, a lot of their time is spent managing prostate cancer. So we would have a very a crisp webinar today. So this would range from topic discussions like focal therapy, prostate cancer biopsy reporting, advances in metastatic castrate-sensitive as well as castrate-resistant prostate cancer. And we would then go on to a debate. Debates are always fun. Between a radiation oncologist and a uro-oncologist debating the role of surgery versus radiation in high-risk localized prostate cancer. And I will be introducing the speakers as we go on. But first and foremost, I think, Roshni, could we have those slides? I just want to give an overview of what we are expecting for today.
Yes, sir.
So that we set the agenda for the meeting. So I would like to, in the meanwhile, tell the participants that we would be happy to take your questions. And, people are wishing us good afternoon, good evening, a very good afternoon or good evening, wherever you're joining us from. And, we would be happy to take questions in the chat box. And my intention as the convener of this webinar is to have a very interactive webinar, as in we have experts and we have subject experts as well as great clinical and non-clinical panelists. So who would give us who would dive deep, including people from nuclear medicine who would be talking about lutetium PSMA. So I think for people at any stage of practice, whether it is even if you're a resident or a fellow, or whether you are a practicing young consultant or an experienced consultant, we would just love to have your questions, and it would improve the flavor of the webinar. So go on to the next slide, please. So today the first talk is by a very experienced uro-oncopathologist, Dr. Murli Verma, who is a leading name in the field of uropathology. Sir has done some great work in the field of prostate cancer pathology and is part of several, panels for guidelines as well. Sir, Dr. Murli Verma practices in Cardiff, Wales, United Kingdom. Is part of the NHS, and he has his training partly, done in India from PGI, and then went on to the US as well as the UK. And I think is finally giving his uro-oncology pathology services in Cardiff, Wales. Sir, it's an honor to have you among us, and you would be talking on prostate biopsy reporting. What is the status in 2025? Thank you. Over to you, Dr. Verma.
Let me share my screen. Right, Ashwin, all good?
Yeah. Yeah, we can see your slides, sir.
Yeah, perfect. Thank you. Thanks to the organizers for the invite. As I was telling Dr. Ashwin, it's always a great pleasure to talk to a audience of clinicians. The topic I was given was the status in 2025, but I'm afraid I'm going to go a little bit more basic and go backward and talk about how to interpret prostate biopsy reports in general. Now, why do we need this discussion? That's because we have a communication gap. We have a communication gap between pathologists and urologists and oncologists, which is probably as wide as the Grand Canyon. Why is that? So if you compare pathology and radiology, urologists and oncologists generally look at radiology images. So they don't look only at the radiology report, they would interpret the radiology report in the light of the radiology images. But when it comes to pathology, unlike radiology, which is anatomy, which surgeons are extremely familiar with, pathology is histology. A lot of it is imagine. You have to reconstruct it in your mind. It's a lot of mind games, which is extremely difficult for a surgeon. So generally, if you see a surgeon at a microscope, he is doing robotic surgery, not looking at histology. So surgeons and oncologists view radiology, but when it comes to pathology, they are entirely dependent on the written words because they do not have access to view the histology images. So the nuances in an individual case have to be very clearly expressed in black and white in the report. So these are pathology reports must bridge this communication gap. And conversely, the clinicians have to be able to interpret our reports correctly. So I don't think clinicians need to know how to diagnose cribriform or how to diagnose Gleason pattern 4. But what they need to know is what does the word cribriform mean and what are the limitations of the pathological diagnosis of cribriform. So that is critical. So when it comes to biopsy data, there's a lot of data that we put in our biopsy results. Diagnosis, extent, grade, so on and so forth. Now, I don't have the time to cover all of this, so I'm going to keep this brief. And since the audience is predominantly oncologists, I'm going to focus on the tumor grade. Now, because when a patient comes to the oncologist, generally the diagnosis has been made, and usually these patients have got advanced cancer, so tumor extent, etc., is less important. So the critical bit for oncologists is often the tumor grade, which is why I'm going to talk about some issues about tumor grade in prostate biopsy reports. Now, when it comes to the tumor grade, there are two things that we tend to report. We report the Gleason score and we report the grade groups. The first thing I think it's very important for clinicians to understand, I think in my experience, the big problem is that clinicians have too much faith in pathologists. So because clinicians don't view the histology material, they take the pathology reports as literally black and white. It isn't. There are a lot of limitations in our reporting, and you have to be aware of that. So when it comes to the biopsy Gleason score, this is only a very rough guesstimate of the tumor Gleason score. The patient outcome does not depend on the biopsy Gleason score. The patient's outcome depends on the tumor Gleason score, and the biopsy Gleason score is only an estimate of that. So here are two very large studies comparing the prostatectomy and biopsy Gleason scores. So you got one from Johns Hopkins with about 10,000 patients and another one from Karolinska with about 15,000 patients. So how good is the biopsy correlation? Now, these are large studies from large centers. So how good is the correlation? So if you look at biopsy 4 plus 4 equals 8, about half of those patients would have a lower grade in the prostatectomy, which means the biopsy had overgraded the tumor. But more significantly, 1 in 5 of these patients, 20% of these patients, had primary pattern 3 in the prostatectomy. So which means the biopsy was 4 plus 4 equals 8, which most clinicians would say this is extremely bad news. But the prostatectomy score was 3 plus 4 equals 7, or in some cases, even 3 plus 3 equals 6 in a prostatectomy. So you can see that there is significant difference between the biopsy and prostatectomy scores. And this is not just about 4 plus 4 equals 8. 3 plus 4 equals 7, about 20% are undergraded by a biopsy. 3 plus 3 equals 6, about a third of the patients are undergraded. So why is this happening? It's not surprising. So if you look at prostate cancers under the microscope, they're extremely heterogeneous. So here you've got a single tumor, and you can see the variation in the patterns. And then it all depends on chance as to where the needle happens to go. So if the needle goes through this area of the tumor, the biopsy Gleason score would be 4 plus 4. If it goes through this area, it would have more 4 than 3, so 4 plus 3. In this area, it would be 3 plus 4, and this area would be 3 plus 3. So the same tumor, depending on the sampling error as to which part of the tumor happened to be sampled, the result in the biopsy report could say 3 plus 3 or 4 plus 4. And then we have this problem, not uncommonly, that in a biopsy that you've got different cores having different scores. So here you've got 4 cores positive. The blue is Gleason pattern 3. The red is Gleason pattern 4. So one core has 3 plus 3, 3 cores have 3 plus 4, and one core has 4 plus 4. So which score should the pathologist report? And more important, which score should the clinician use? So should the clinician treat the patient as a 3 plus 4, or should the patient be treated as a 4 plus 4? It depends. So when you look at this, the pathologist could report the global score. So considering all this as one single tumor, in which case the Gleason score is 3 plus 4. Or you could report the worst score, which would be 4 plus 4. Now, if this 4 plus 4 core is from a separate tumor, so you've got 2 tumors in the prostate, one is a 3 plus 4 tumor, and the other is a 4 plus 4 tumor, and the 4 plus 4 tumor is where all this nasty stuff has come from, then clearly the correct Gleason score for treating this patient would be as a 4 plus 4. However, what about this scenario? That where you've got one core which has got a small amount of tumor, which is all pattern 4. This patient is very unlikely to have a separate high-grade 4 plus 4 tumor. Much more likely, what he's got is a 3 plus 4 tumor, and one core just happened to sample only the pattern 4. So the idea that this patient should be denied surveillance on the basis that he's got 4 plus 4 tumor really doesn't add up. So this is part of the problem in our pathology practice. So some pathologists would report the global score. Some pathologists would report multiple scores or the worst score. Now, is this correct? So which score is appropriate? So in some cases, the worst score is appropriate. In other cases, the global score may be appropriate. So one option for the pathologist would be pass the buck. Report all the lengths of tumor, report all the Gleason scores, and let the clinician choose as to which score is likely to be the appropriate score to manage the patient. So you've given all the data to the clinician. So what do clinicians do? So this is a study that we had conducted some years ago where we surveyed urologists and oncologists in the United Kingdom. And no surprise, about 80% of the clinicians would simply ignore the millimeters, just look down the column of the Gleason scores, and if you give them 4 different Gleason scores, they just go with the largest number. So 78% use the highest Gleason score, ignoring. So they would manage this patient as 4 plus 4, even though this 4 plus 4 was in a 1 millimeter focus. So this is where we have a problem, because the clinicians do not view the pathology. They are dependent entirely on the histology. So it is our responsibility as a pathologist to help the clinicians interpret the report. So when I sit in the multidisciplinary team meeting, my job in the MDT is not to read a histopathology report that is written in English. Most of my surgeons and oncologists, their first language is English. They can read it as well as I can. So my job in the MDT is to actually help interpret my report and where there are problems to explain it. So this was a paper that we published, and we feel very strongly that when it comes to choosing the Gleason score to treat the patient, that is not the urologist. The urologist cannot decide that because the urologist doesn't look at the slides. So the Gleason score assignment is the sole responsibility of the pathologist who has viewed it. So because the pathologist is best placed to identify the right score, and which may be global or worse, based on the patient's, on the pathologist's judgment of an individual case. Then we've got this thing about the new grading system for prostate cancer. Well, the point I would like to make is there is no new grading system for prostate cancer. Clinicians have always grouped the Gleason scores. So what was done here was just a different grouping of the scores. So we had from 1 to 5, and this does not add any extra information. The grade group does not provide any additional information. It can, if I report only the Gleason score, the clinician and the patient could derive the grade group. In fact, there is less information, because when I report something as grade group 5, that could be 4 plus 5 or 5 plus 4 or 5 plus 5. And there are studies saying that there is a difference in the outcome. And similarly, grade group 4 could be 4 plus 4, could be 3 plus 5, or could be 5 plus 3. So the main reason for doing this was to make it more patient-friendly. So this was because patients started reading reports. And when they started reading reports, there was a problem. Because when they saw the Gleason grading system is from a minimum of 2 to a maximum of 10. So the assumption was Gleason 6 is somewhere in the middle. So patients misinterpreted it as intermediate. So which is why I think Jonathan Epstein's idea of not just having groups, but giving them numbers from 1 to 5 made a lot of sense. Because now the report says grade group 1, so it is more obvious to the patient. So let me summarize what I'm talking about. At the end of the day, medicine is not mathematics. You cannot reduce this to simply numbers. Patients cannot be treated by numbers, and there is no substitute for pathologists using their judgment and for clinicians using their judgment. So I'm going to end with this case study. Here's a first biopsy. The patient had 2 cores positive, 3 millimeter, 3 plus 4 equals 7. He opted for active surveillance. A rebiopsy after 1 year, the number of cores increased from 2 to 4. The tumor length increased from 3 to 10. The Gleason score increased from 7 to 8. So has this tumor progressed? If that is the histology, then yes. But you've got to look a little deeper. So when we say Gleason score 4 plus 3 equals 7, primary pattern 4, bad news. That is true in a 20 millimeter tumor. But if you've got a 2 millimeter tumor with 80% pattern 4, that is very little pattern 4 in the biopsy. So that's where we have to interpret. So in this case, where you've got a small amount of tumor, it is reported as 10 millimeter because that was discontinuous tumor. And the total length was 10 millimeter. It was reported as 4 plus 4 because one tiny core or bit of tumor was only Gleason pattern 4. So in this situation, the patient had not progressed. So when you get this rebiopsy report, you can't just go by the numbers. So you have to look behind the headlines. So you have to actually interpret what's in there. And that's where you need the pathologists and the urologists and the oncologists to work together. Thank you. Right. Happy to take any questions.
Yeah. Thank you, Dr. Verma, for an excellent overview. I know that you cannot do full justice of all the experience that you have garnered over the years in just 12 minutes. But I think we will clarify a few things by asking some questions. So first of all, I'd like to ask you, how has, nowadays, even we are doing a lot of fusion biopsies, MR fusion biopsies, cognitive fusion, as well as the software fusion biopsies. How much of a discrepancy, whether it's upgrading or downgrading, do you see over the years? Has it decreased because we are able to target lesions more accurately, even the ones that are like 10 mm or lesser, we are able to target them well? And do you see that this has helped in the practice?
It has helped, but there's a mark limitation. Now, prostate biopsies are unique because there's no other organ where you stuck blind needles in and hope for the best, right? There's no other tumor, to my knowledge, where non-targeted biopsies are done. So doing now, when you do an MR and you got a pyrite lesion and you're targeting it, that is a marked advance. So that's definitely better than the non-targeted biopsies. Because in a non-targeted biopsies, if I had four cores positive, there is no way for the pathologist to know whether all these four cores are from one tumor or are they from four separate tumors. When you do this from a targeted biopsy, we know that all these cores have come from the same area, they're from the same tumor. So that helps. However, even in a targeted biopsy, like I showed you with that case, where because the tumors are so heterogeneous, there is still a hit and miss. So the correlation between the biopsy Gleason score and the true Gleason score, even in a targeted biopsy, is not great. Ashwin, if I can make one other point, which is extremely important. In all other organs, if you consider breast, you do a breast biopsy. If the patient's got localized breast cancer, you're going to get an excision, either a wide local excision or a mastectomy. So you will get a definitive grade and a definitive stage. The problem in prostate is less than 1/3 of the patients we get a definitive grade and a definitive stage. Because all the patients who go for surveillance, all the patients who go for radiotherapy never have an excision. So we never have a final grade and scores. So what I'm trying to say with prostate, you have to accept that there will always be a degree of uncertainty.
So would it suffice to say that we are taught in our surgical training that when we interpret the Gleason scores, the primary and secondary for a biopsy, so the primary score is the most prevalent score, the secondary score is the highest score that you see in the biopsy, in the core biopsies. Whereas for a radical prostatectomy, primary score is the first most prevalent, and secondary score is the second most prevalent, and the tertiary score is the highest score that might be there. So
right. Can I just clarify that? I think this was a little bit of confusion. The original Gleason grading system said the most prevalent score is a primary score, the second most prevalent score is a secondary score, and that was it. But the problem was the Gleason grading system. Donald Gleason had no biopsies, so these were all large specimens. He had a few thick core biopsies, very different. So now in the biopsy setting, if you got even a small amount of pattern 5 or pattern 4, that means the patient has that. We can't ignore that because there could be a significant amount of that. So which is why we now introduce that into our Gleason score, right? So now in the biopsy setting, even if there's a small amount of higher grade tumor, less than 5%, or if it is a tertiary pattern, we include it as a secondary pattern. The problem with doing that has also led to marked overgrading. There's no doubt about that. There's been a huge shift in our Gleason grading. In the prostatectomy situation, the Gleason score in a prostatectomy really has limited clinical utility. Certainly in the UK, in our practice, patients go on to PSA monitoring. So there very rarely that patients are given adjuvant therapy based on the Gleason score. It's usually more seminal vesicle involvement, lymph node mets, and that sort of thing, rather than the Gleason score. But over here, what we do is a primary score. The second most prevalent is a second. But if you've got pattern 5, which is more than 5%, which means more than a little bit of pattern 5, we now put that into the secondary score. So even in the prostatectomy situation, that's the way we do it. Finally, there's a little bit of complication. I'm sorry, I hate to get into these sort of nuances because I think it's unnecessary confusion. We've got two pathology societies, ISUP and GUPS, which have got different guidelines. So if you've got 3 plus 3 with less than 5% pattern 4, ISUP recommends reporting it as Gleason 6 with less than 5%. GUPS recommends reporting it as 3 plus 4 equals 7, less than 5%. Exactly the same message causes a lot of confusion. And to be honest, I don't think urologists care.
Very true about that. One last question, sir, if I may bother you again, is about intraductal carcinoma as well as the cribriform pattern. So because this is predominantly clinicians, what is your take on that? Should we treat these aggressively if we find any of it? What is your take on this?
Yeah, I think this is, Ashwin, this is a half an hour lecture. Okay, so if we go into introduction and cripple form, the rest of the program will not happen.
Okay.
So it's extreme. So all I can say is this much: it's extreme. A lot of this is extremely controversial. A lot of this is based on very suboptimal data. So to be honest, we don't have the necessary data. What we don't have is the clinical outcome of patients with intraductal carcinoma in a biopsy who are otherwise suitable for active surveillance. There is no doubt that intraductal carcinoma is generally associated with aggressive, high volume, high grade, high stage invasive cancer. So that there is good data on that. Rarely we see we see either pure intraductal carcinoma or we see 3+3 with intraductal carcinoma. But the majority of these patients do badly. But the amount of data we have is still very limited. So is that suffice? I can go in more details, but it will take a lot
Yeah,
of time.
I think so. I kept this as the first talk deliberately because I just want to attach so much importance to pathology. I think without pathologists, we would be unable to do what we do on a daily basis. And thank you for that. And thank you for being a beacon of light in this field. Thank you, sir. With
Pleasure.
that,
Thanks
I would
again
thank you
to
so much.
organize this.
With that, I would move on to the next talk. Roshni, if we could have the slide for Dr. Santosh. Uh, the the yes. So the next speaker, Dr. Harshit, would be joining us later. So Dr. Santosh, excellent uro-oncologist and a dear friend, and Dr. Santosh has trained in India and is currently in the United Kingdom in a very high volume focal therapy center, which is University College of London Hospital. And what is commendable about Dr. Santosh, after having finished his robotics urology training, robotic uro-oncology fellowship in Mumbai, was practicing as a consultant. He left a plum opportunity to be in India and serve, and just so that he could go and learn newer techniques and probably bring them back to India. So he has seen the whole spectrum from radical surgery to focal therapy. And he's currently a clinical fellow at the University College of London, working with some leading focal therapists of the world. And Dr. Santosh, it would be a pleasure to have your talk on focal therapy state of the art.
Thanks, Ashwin. I'm just sharing my slides. Can you see them?
Yeah, we can see them now, Santosh.
Okay, thank you. So thanks, Ashwin. And I think I totally agree that pathologists are very important, especially from focal point of view. And I'm going to quickly run through this. So disclosures would be, I don't have any company affiliations. I'm a uro-oncologist. I'm a trained robotic surgeon. I'm also trained in focal therapy. So I sit on both sides of the table to have a wider perspective about the subject. I would be covering the topic in looking at traditional approaches, why focal, two important determinants of focal therapy, types of focal therapy, and brief literature review. We all know that digital rectal examination, PSA testing, ultrasound, and biopsy and MRI are something which we do to do prostate cancer risk assessment. And once the risk is assessed, we either do an active surveillance or surgery and radiation. There are few people who would go into only hormones or watchful waiting. But there is a spectrum of patient in between that I'm going to talk about, which would be asked to undergo focal therapy. Now, is there a need of focal therapy? The question commonly asked is the focal therapy still knocking on the doors? My answer to it is the era of knocking on the door is gone. It is already in the house, sitting on the table and having a meal with everyone else. So if we look at this paper, there are some variations in patient-reported urinary outcome 3 months after radical prostatectomy. It's a statewide study. And even now, the rates of adequate erectile function after radical prostatectomy do not appear to have improved over the last decade. We looked at our own data of 2,000 men in UK after prostatectomy. looking at their status in leaking urine and erections, we found that men after prostatectomy, 1 in 3 need pads at 12 months, which will approximate to a mean epic domain score of 78. And in men with erections sufficient enough for intercourse with no assistance, 1 in 20 had erections without assistance, which would be a mean epic domain score of 34.8. With radical radiotherapy, we all know that impotence and urinary issues is an issue, and rectal toxicity is where radiotherapy scores much over radical surgery and focal therapy. Active surveillance has its own challenges. It can be associated with anxiety. Men with intermediate risk prostate cancer have 50% chance of delayed treatment and risk of stage progression around 1 to 2% of MRI visible 3+4 disease. Now, can focal therapy, can it join the venue? It can, and let's see how. It started with the concept of Halstead doing mastectomies, radical mastectomies, went down to lumpectomy, and somebody picked up the concept in prostate, and Hush Ahmed from UK has published this paper. They looked at index lesion as the main lesion contributing to the spread of disease and not multifocality. And he went on to add another paper saying that the genetic composition of patients who've got METs or who have spread of disease is similar to the index lesion. So the concept coming up was, if we treat the index lesion right at the start, do we help to get the patient avoid any metastasis or spread of disease or progression of disease? Now, the next question is, what is focal therapy? There are many definitions available. There are many definitions that I've heard, but what I like to keep it simple, what I tell the patient is it's a type of tissue preserving surgery which treats that part of the prostate which has MR visible cancer, which is localized and clinically significant prostate cancer. Now, these two words are very important. I'll emphasize now. We asked a group of experts. Now, what is the 3 most important criteria they look into whether when they decide to put the patient on active surveillance or active treatment? Gleason grade, MRI, and PSA density were the first 3 as a consensus with all the consultants. We all know that most of the patients would be Gleason 3+4 going for prostatectomies. And we also know that the percentage of pattern 4, as explained in the previous talk, is extremely important because that defines how the prostate cancer will behave after the treatment is delivered to the patient. The second most important point after Gleason score is MR visibility. MRI gives us information and location of the tumor. Some papers looked at it after prostatectomy and they found that MR visible disease, 40% have biochemical recurrence, 20% have metastatic disease at 15 years, and 7% prostate cancer have mortality. There are papers which also suggested there are 3 times more likely to lead to biochemical recurrence after radical treatment than non-visible disease. Genetic sciences also emphasize that MR visible have got different genetic composition, which makes it probably more aggressive than non-visible disease. And this paper from our side looked at 5-year data on patients with active surveillance. We have a 10-year data coming up. It's all for publication. I can't divulge the readings, but what it said is that 3+3 visible disease tends to progress more than 3+3 non-visible. 3+4 visible disease is more aggressive than 3+4 non-visible disease. So we are going into the visibility of prostate cancer. Hence, prostate cancer MRI allows us to see cancer differently, and seeing cancer differently allows us to treat cancer differently. So does one modality fit all? Certainly not. When you look at indications, as I said, we have got Gleason 3+4 and some cohort of 4+3, 4+4, which is subject to patient discussion. And the contralateral side, if it is low volume 3+3, 5 mm, it can be kept on active surveillance. To add to this, I would also put in the MRI criteria of whether it is seen properly on the MRI, because we need to get a margin around the cancer when you treat it, and where is the location of the tumor to select the type of procedure you want to do. So if I want to go back, you see anterior tumors are treated with cryotherapy and cryotherapy and nanoknife. Posterior are treated with HIFU. These are the types of focal therapy. I would restrict myself to first 3 because that's what I'm trained in and that's what I do. And as I said, the anterior gland are more treated with needle-based transperineal therapies like cryotherapy and electroporation. I'll discuss that in a moment. And posterior gland are treated with ultrasound-based treatment called HIFU. Now, this is a HIFU. You can see the ultrasound machine there, and that's how the ultrasound generates heat at a focal point, and that starts to burn the cancer. It's like using a magnifying glass against the sun, and if you focus it on a piece of paper, the paper will burn, but nothing in between that. If you move ahead. So this is one tumor I want to show where you have a left low T2 signal in the PZ, and there is the effusion. The biopsy showed 3+4, 12 millimeter prostate cancer, and he underwent HIFU. You can see on the, I'm showing with the marker on the top left side, you can see white changes are called Ushida changes, where the cancer is getting heated up, cooked up. And on the right side, we monitor any complications or any heating in the rectum, which we can address immediately to avoid any complication. And these are the sectors which we treat with the cancer. And this is what it looks like after it is treated. The whole cancer is being treated, and there is no visible evidence of any effusion or any enhancement is seen in the MRI. Cryotherapy is making ice balls in the prostate, where you can see an ice ball is created, and that's how it kills the cancer. If we go to the next slide, you can see this is what I have shot, and this is how the probes produce the ice ball in vitro. So going to the next slide, this is one patient I wanted to show. This is an anterior tumor. You can see in the TZ, the needles are placed in, and when we go in, you can see the ice ball expanding on the left top side. That's the ice ball expanding and killing the cancer. And that's on the sagittal view, you can see the ice ball treating the cancer as well. Nano knife for electroporation is generating electric current enough to not cause heat. Now, what it does, it opens up nanopores. This is an electromicrograph of the cell, and when the nanopores are opened, that causes the cell to undergo autolysis. And this is another treatment. That's the patient in lithotomy position. You can see that's the tumor on the top left, and that's the yellow dots are showing how the needles are placed around the tumor, and that's the red thing is showing the electric field that is generated along it in between the two needles to destroy that's the real needle placement ultrasound view. And this actually what happens, it's called pulse treatment. You can see the electric current killing the cells. And at the end of it, you can see this cavity here. And that's how. Let's look at the trial which affects routine practice. Now, in focal therapy in UCLA started off treating all the cancer. We gradually moved on to focusing only on the area which has cancer in it. And now we practice what is called as lesion control, HIFU, where we focus on only clinically significant cancer, and then the cancer is left behind. When we looked at all these treatment modalities, we saw a very good drop in PSA after treatment. And we also saw that the erections were sufficient enough, and which was a good sign, and which shows that the patient can have good functional outcomes after treatment in forms of erections and passing urine. Rectal toxicity is practically zero. And if we move ahead, this is the recent study which looks at focal ablation in 56 men. And you see around 89 to 90% of these men had no clinically significant Gleason score, Gleason 3+4 or more, on treated side at 6 to 12 months. That's when we used to do the biopsies, but now we don't do any biopsies after focal treatment. This is a repetition of the slide which shows which treatment to use when. Now, why is it important to divide treatment into anterior posterior? Our study showed that there is treatment failure around 20% in posterior tumors, around 37% in anterior tumors. So the dictum is only use HIFU for anterior treatment if there is very small gland. It involves a little bit of calculations and measurements on the MRI, but you need to be very clear of what you are choosing. What margin should we apply? Now, if the radiologist draw a margin around the tumor and we treat it, we are going to miss 15%. Hence, the recommendation is take margin of 9 millimeter to cover 100% of histology volume. Now, what happens when we move from clinical studies to routine care? Now, this is a study done at our center by Armando, and we look at 70, as expected, 70% was focal therapy, 30% were hemiablation. most of the Gleason's was 3+4, which was treated by us. We went down on 3+3 only if it is significant, only if if it is visible, the patient wants it, we give it. And small cohort of patients of 4+3 receive the treatment. The overall survival is 97.3% at 5 years. Radical treatment-free survival is 80% at 8 years and 91% at 5 years. Need for additional treatment, 70% don't need, but 20% may need second ablation and 6.5% may need radical treatment. This is important when we counsel the patient. When you talk about focal and hemiablation, there is no difference in recurrence rates. When you talk about learning curve, retreatment rates are reducing over a period of time with proper patient selection, improved imaging, and operator experience. Exception to the usual rule is sometimes we treat non-visible 3+4 with hemiablation if it's a young patient keen to complete family and concerned about his erections and ejection, but not ready to accept radical treatment, and occasionally treat PSMA positive MRI negative tumors. When we look at trials comparing radical with focal therapy, we look at a propensity matched trial, and we saw that the 3-year failure survival rate, 5 and 8 year are almost the same. This is important because because the patients are under the impression that if they undergo radical prostatectomy, they are cured, which is not. And this is an important slide, which would be a take-home message that can be used to counsel the patient. In summary, with focal hemiablation, less than 1% pad use for incontinence, that's from the HEAT registry. 1 in 3 need tablets for erections, 2 in 3 natural erections, reduction in semen volume in more than 50%, and 1 in 5 need second HIFU by 5 years, and 1 in 15 may need radical treatment in 5 years. Again, focal therapy depends on tumor characteristics, as I said, tumor visibility, location, and next would be what energy you're going to use, whether it is posterior, anterior, whether it is heat for HIFU, whether it is cold for cryo, or electricity for nano. And the treatment plan is accordingly decided whether it will treat hemiablation or only focused treatment. So to sum it up in my penultimate slide, it is more preference sensitive discussion. We tell them the advantages, we tell them the disadvantages, but at the same time, all options are offered to the patient, including radical, and if they are eligible, then active surveillance as well. So in summary, prostate cancer is a spectrum of disease. Men at low risk won't benefit from treatment. Radical treatment can significantly function impact, but at the time of counseling, all 3 options are offered. Focal therapy offers personalized treatment, 1 to 2% low urine leak rates, preservation of function, excellent cancer control, less than 5% radical treatment at 5 years, and 20% redo focal treatments. Thank you. This is a team of people who I work with, and it's an absolute pleasure. We have Mr. Emberton, who probably would be visiting in mid-August to India, and it's a pleasure to work with all these things. Thanks, Ashwin. I'm happy to answer questions.
Thank you, Dr. Santosh. Excellent talk as always. Didn't expect any less than that. So yeah, we are looking forward to Professor Emberton's arrival. I know he's coming soon, so we're all looking forward to that. Probably I might make a trip to Mumbai. Okay, so Santosh, I have a couple of questions for you.
Yes, go ahead.
So you have now done the whole spectrum of prostate cancer treatment. So you started as a urologist, and then you became a uro-oncologist. Went on to do excellent, good quality robotic radical prostatectomies, and were doing very well. And now you have been doing high volume focal therapy as well for prostate cancer. So for an ideal case of HIFU, which you think you can manage with focal therapy versus radical prostatectomy with good continence in your hands, probably within a month or 2, patient is pad free. So what is your preference now, since you have seen both sides of the table?
Yeah, so I mean, that's a good question. It's at the same time, there is a little bit of trickiness in it, but I would attempt to answer that, Ashwin. So this is a common scenario we face in the clinic. The patient comes to us after talking to the surgeons, or they go from us after talking about focal therapy. Now, if I am in the seat and if I'm doing both and often, so I'll be, as I said, the discussion involves both, right? We talk about prostatectomy, we talk about focal therapy as well. And to be honest, to be very, very honest, and it's not because I'm doing focal and I'm not doing any disservice to the radical prostatectomies, but we see patients asking to get converted into focal because, as I said, they are very keen on maintaining their ejection, the erectile functions and urinary continence. And I think the awareness has gone up quite a bit. I think it all depends on the cohort. So if I am, it depends on where you are counseling the patient, to be honest, Ashwin. But if I'm talking to a patient from India, it would be a different logistics, to be honest. And that's where patient awareness comes into picture. If the patient is really, they are not happy following up with biopsies or maybe PSAs and repeated MRIs, then prostatectomy would be the go for. Again, the explanation would involve what risk they are taking. But if the patient is well informed, which they would be in coming times, uh, they would offer focal therapy, and we are happy to give them. But again, I would like to mention here that there are cohort of patients who will not be suitable for focal therapy. Like if it is very close to the sphincter, if it's very close to the bladder neck, we cannot offer focal therapy, right? We can't do cryo if it is close to the bladder neck. We can't do nanoknife if it is close to the sphincter. We can't do focal therapy if you have clinically significant disease on both sides. So all these factors do come. So counseling is a very, very big part in focal therapy.
Excellent. So one point that struck me, and I think now as uro-oncologists, all of us are following this, is that a good quality MRI is a must before we do a biopsy. So I think, as Dr. Santosh has rightly put, so MR visible disease, even if it is 3+3, has is more aggressive than those that aren't MR visible. So MR visibility is a key point, and now we have all moved on to either MR cognitive fusion biopsies or software platform fusion biopsies. So I think all the clinicians here should take home that point that before we are doing a biopsy, an MR is very important. And what about post-focal therapy recurrences? And how are you dealing with them? Is it a refocal therapy discussion, or do they opt for radical prostatectomy in your practice in London there?
Right. Right. So I'll give you a quick example, right? So if you divide the prostate into left and right, okay, you treat the left side of the prostate with focal therapy. So the risk of having a recurrence and going for a second focal therapy is 1 in 5 years. The risk of recurrence and not being eligible for focal therapy, but going to radical options is 1 in 15 patients in 5 years. Okay. Now, again, now that's the first point. Second point is where the recurrence has occurred. If the recurrence has occurred on the right side, when I've treated the left side, we see what type of recurrence it is. It is called out of field recurrence. Okay. If that is high grade and not amenable to focal therapy, then we ask them to go for radical options. But if it is amenable to focal therapy, we can do a focal therapy. That's called a second focal therapy. A redo focal therapy is done on the same side where he has received focal therapy earlier. All right. Now, if the recurrence in the same side, Ashwin, if it's less closer to the sphincter, we will not offer focal therapy. It's better for him to undergo radical options. So these are called in-field recurrences. So these are things which we take. That's why MRI reading, again, not only before taking up the patient, but after treating also, MRI reading is extremely important.
So excellent answer. I think mental note here for me to involve the radiologists in our next webinar. I think just like pathologists, they are sacrosanct to our practice. Thank you, Santosh. It would be great if you could hang around and probably enjoy Saturday in beautiful London today. And we will be having some panel discussion. So if you can just chip in, we'd be happy to.
Absolutely.
Thank you. Thank you so much. With this, we move to the next talk. So, Roshni, yes, put up the slide for Dr. Vishwanath. So, Dr. Vishwanath is our next speaker. He would be speaking on castrate-resistant prostate cancer. We are doing castrate-resistant before castrate-sensitive because Dr. Vishwanath had other appointments to get to. So, without wasting much time, I would just like to introduce Dr. Vishwanath. He is a senior consultant medical oncologist from an academic advisor of the DNB Medical Oncology Program at Apollo Hospitals, Bangalore. He is an award-winning oncologist, and he has over 45 international peer-reviewed publications. He is a member of the ASCO Cancer Communications Committee and the ASCO Annual Meeting Educational Committee. While doing all that, he still manages to get time to run a non-profit organization called CPOEM, which is doing excellent work in the field of oncology communication. And for that, he has even been mentioned by the president of ASCO. So it's excellent, Dr. Vishwanath, to have you amidst us. Looking forward to your talk. Please take it away.
Yeah, thank you so much. Roshni, can you allow me to share my slides?
Yes, sir.
Perfect. Yeah. Good evening. First of all, at the outset, I would like to thank Dr. Ashwin. He's a dear friend. Thanks for this wonderful opportunity. And, it's an absolute pleasure to be with all of you this evening. So my topic for today is on castration-resistant prostate cancer, the latest trials and updated evidence. So I will probably run through quickly on non-metastatic CRPC and then how to come up with the decision making and the key clinical trials, and then go on to the metastatic CRPC, and then talk about PARP inhibitors, radioligand-based therapy, immunotherapy, and some emerging drugs. It's a really exciting time to be in medical oncology, a lot of novel drugs. So I would also run through that very quickly. So if you see the clinical course of prostate cancer, it's mainly, if the patient starts with the locally advanced prostate malignancy, and then you give definitive therapy, you identify metastasis that becomes a de novo metastatic, or if it could turn out to be a metastatic HSPC, or the patient could directly land with a de novo metastatic HSPC. But then if the localized disease, there's a rising PSA, there's a biochemical recurrence, and then you could call it a non-metastatic HSPC, and then you start androgen deprivation therapy, and then there's a further rising PSA with castration levels of testosterone, and that becomes a non-metastatic CRPC. So non-metastatic CRPC again remains incurable and the cause of death for patients who die of prostate cancer, and of course we have the metastatic CRPC as well. So, what is the non-metastatic CRPC? If you see the definition, it's basically a minimum PSA rise of 2 nanograms per ml, confirmed with second value obtained 1 to 3 weeks later. The patient could have some prostatitis, so it's always good to repeat a second value. And a 25% increase from the PSA nadir, and castration levels of serum testosterone to call it a castration resistant. And the usual number is less than or equal to 50 nanograms per deciliter, and no evidence of metastasis with conventional imaging. So this is the natural history of rising PSA in non-metastatic setting. And if you see here, it very clearly says that at 2 years, 33% of patients will develop at least one bone metastasis. And the PSA doubling time predicts shorter time to first bone metastasis. And metastasis-free survival in the non-metastatic CRPC is a very good surrogate for overall survival. So various factors when you talk about decision making, and I'm sure it's a multidisciplinary tumor board with urologists and radiologists and the pathologists. And what you look at is mainly quality of life, and you want to look at the efficacy. You want to improve the outcomes. You look at the metastasis-free survival. You want to make the patient survive longer. And of course, if you have to look at other comorbidities, most of them will be in the geriatric age group. So get the geriatrician involved, and also look at the drug-drug interactions and to make sure that the patient gets the right drug. So 3 main trials in the non-metastatic CRPC setting: the Aramis trial, which looked at darolutamide and compared it with placebo. And then again, the primary analysis, it was the metastatic free survival, and the final analysis, of course, the overall survival. And then we have this Spartan trial, which looked at apalutamide, and then the Prosper trial, which looked at the enzalutamide. So 3 androgen receptor pathway inhibitors studied in the non-metastatic setting. And the baseline characteristics, if you see, it's a cross-trial comparison. If you see, most of them were all well matched. And the only thing what is important to note here is that the N1 disease, a small percentage was seen in the Spartan trial, was included in the Spartan trial, as well as the Aramis trial. And see, if you look at the enzalutamide study, look at the PSA progression and the median time to progression time to progression, PSA progression. Look at the Kaplan-Meier curve, early separation of curves, And you can see that enzalutamide does really well. And look at the hazards, 0.07 in a solid malignancy. That's just fantastic, Looking at these kind of hazard ratios in solid malignancy is very, very impressive. And then comparing all these three trials, if you see the metastasis-free survival, nothing much to separate between these three. And it's around 40 months to be precise. And the hazard ratios, again, 0.41 in the RMS, 0.29 in the Prosper, and 0.28 in the Spartan trial. And if you look at the overall survival, if you look at it, the hazard ratios are around 0.7. So there's a 30% reduction in the risk of death. Just goes to say that these ARPIs work very well in this particular setting. And of course, the other meaningful endpoint is time to symptomatic skeletal related events, which also gets better with all these three drugs. So the take home message, it's not very common as a medical oncologist. I don't see it very commonly. I'm sure Ashwin and the urologists do come across this very often. And all these three ARPIs demonstrate clinically meaningful benefit, good improvement in the metastasis free survival, good improvement in the overall survival, and also time to first skeletal related events. And most importantly, no new safety signals, and they all are very well tolerated. So these three trials have kind of they've made a paradigm shift in the way non-metastatic CRPC is looked at. So this is how is the landscape of metastatic CA prostate. If you look at this, so it's become so busy. There's a plethora of drugs in the CRPC setting, and so many drugs. You look at depending on whether the patient has had prior chemo. You have the ARPIs, and then you have PARP inhibitors. Now you have radioligand therapies, and then you also have immunotherapies, and there's a lot of emerging new drugs as well. So it's all important. It's important to know where to go. But to know where to go, we must know where we have been so far. And considering alternative mechanisms of actions is the key. And that's how you can probably give the best possible survival to your patient. So there's a major unmet need in the metastatic CRPC setting. So just to define CRPC, prostate cancer that progresses clinically, radiographically, or biochemically despite castration levels of serum testosterone. And we know most of these patients would have received the ARPIs, they would have received chemo, and that's where there's a major unmet need. And if you look at the survival as with so much of visceral metastasis, I think the survival just gets dismal. So there's a major unmet need in this specific subset of disease. So it all depends on what kind of treatment the patient has received, whether the patient has visceral metastasis or bone-only metastasis, how is the cancer progressing. Certain patients are very asymptomatic, or certain patients are in visceral crisis, lot of disease, lot of visceral mets. Is the patient candidate for chemotherapy? And most importantly, we keep biopsying these patients to see if there's neuroendocrine transformation, which occurs in 15% of the patients. Are there any targetable mutations? What options are available in our practice? We spoke about UK, US, but we are living in India. What kind of options do we have? And do we have any options of clinical trials? Various questions come to us, and this is how we probably address and tailor therapy to our patients. So if you look at germline HRR mutations, the landscape of metastatic prostate cancer, 10 to 12% of them will have some kind of germline mutation positive. And it's very, very important to make sure that all metastatic prostate cancer patients should receive genetic testing, the germline testing, and most importantly, if you want a tailor therapy, if you want to do a biomarker study, it's always important to do a somatic testing, which is done on the tissue, and it is usually done by the next generation sequencing. So this is again the same repetition. And so what is the rationale of combining PARP inhibitors and ARPIs? Just to explain very simply to a patient, they're mutually very synergistic. ARPIs induce a phenotype resembling HRR deficiency, and the suppressed androgen receptor function causes an upregulation of PARP. So if you give a PARP inhibitor with an ARPI, there's a synergistic action, and that's so probably the patient's tumor, there's a tumor cell death and further benefit. The very three important trials looking at PARP inhibitors and ARPIs. You have the PROPEL trial, which looked at olaparib plus abiraterone, and it was 1:1 randomization, and the other arm was placebo plus abiraterone. Good number of patients, totally 800 patients. And then you have the magnitude trial, which looked at the HRR, BRCA mutated positive, looking at niraparib plus placebo, and in the other arm, niraparib plus abiraterone versus placebo plus abiraterone, and in the other arm it was HRR BRCA mutation negative. Again, niraparib plus abiraterone versus placebo plus abiraterone, and the other one was the talopro trial, which looked at talazoparib plus enzalutamide with placebo plus enzalutamide. Very important trials addressing the key answer whether PARP inhibitors are useful in combination with the ARPIs. And this is, I won't bore you too much with this schema, but look at this kind of a radiological PFS at 24 months. 51.4% favoring the abiraterone plus olaparib arm as compared to 33.6% in the placebo plus abiraterone arm, and the hazard ratio of 0.66. And if you look at the overall survival, this is all comers, it was 0.81. But what is important to note, if a patient had a BRCA mutation positive or a somatic or germline, look at the curves, how well they separate and the benefit with adding PARP inhibitors. So definitely in BRCA mutation positive, it's important to give one of these PARP inhibitors. That was about olaparib, and then you have talopro-2. Very similar results. Look at the radiological PFS, and you can see the separation of curves. And most importantly, recently there was an updated analysis of the HRR deficient population at the ASCO 2025 annual meeting. And look at the forest plot. Everything is favoring towards talazoparib plus enzalutamide. All the HRR genes, it's all favoring the talazoparib plus enzalutamide. That again reinforces the fact that it's important to do NGS in these patients. And the overall response rates are also better. So overall, I think even in HRR mutated patients, it's important to consider talazoparib. And this was the other trial which looked at, it's called the BRCA trial, which looked at olaparib plus abiraterone, or giving olaparib alone or abiraterone alone, but the patients were allowed to cross over sequentially in case of disease progression. Again, it shows that the combination of the olaparib plus abiraterone benefited these patients. And the response rates were also extremely good. So the magnitude trial, as described previously, this was for the niraparib. Again, radiological PFS. Look at the separation of curves, and there's a risk of a significant reduction in the risk of progression of death by 47% in patients who had a BRCA mutation positivity. And even in the HRR BRCA mutated patients, you can see the radiological PFS separation of curves. So, and this again goes to say that the combination works very well. So this is a summary of all three. So if a patient has got a HRR gene rearrangement, you could definitely use talazoparib. And if the patient has got a BRCA mutation positive, you should consider this combination of olaparib or one of these PARP inhibitors with the ARPI. Now moving on, it's really a very there's a lot of provocative evidence in the PSMA-based radioligand therapy. A lot of phase 3 trials in the CRPC setting, and we know that there's a target which is a tumor, and then you have the receptor, and then you have the antigen, which is usually the PSMA antigen, or which is generally the target, and then we also have the ligand, which is usually either lutetium or radium, which is usually used as a radioligand. So this was the VISION trial, which included again PSMA positive metastatic CRPC. And if you see here, the patients were randomized to, and the patients were allowed to have one prior AR pathway inhibitor and one taxane, usually docetaxel is given, and the patients were randomized to the lutetium arm plus the standard of care versus the protocol permitted standard of care. And if you see here, the overall survival was better in the radioligand arm, and you can see that the hazard ratio was 0.62. And it was well tolerated. If you see the life-threatening side effects were all in single digits. And the other one was the PSMA-4 trial, which is a specific trial looking at taxane-naive patients, again, a lutetium-based PSMA. And in the other arm, it was ARPI change, abiraterone or enzalutamide. And if there was a disease progression, the patients were allowed to cross over. And you can see that, again, there's a significant benefit with the lutetium as compared to the ARPIs. And then this was the SPLASH trial, which again looked at, it was a phase 3 study, and again, lutetium-based therapy, but a different dosage. and in comparison with abiraterone or enzalutamide. And if you see here, there's the primary analysis of the which looked at the radiological PFS, good separation of curves, hazard ratio of 0.71 for the radiological PFS. So again, goes to say that radioligand in combination, is the way to go. And now there are a lot of combination therapies also being studied with immune checkpoint inhibitors and with other therapies as well. And if you see, overall response rates was also quite good. And a lot of new data is coming up with actinium, which is an alpha emitter. And then there's a whole lot of radioligands which are being studied as well. Now there's coming to the novel drugs, a lot of exciting drugs. In fact, EZH2 inhibitor is being used for follicular lymphoma, but over a period of time, we realize that it gets used for other cancers as well, and prostate cancer is no exception. EZH2 is involved in the epigenetic pathway and plays an important role in lineage specification. And prostate cancer, what happens? There is a lineage plasticity, and so EZH2 inhibition definitely has benefit in patients with prostate cancer, especially the CRPC. One drug which is of interest is the mevrometostat. And if you see, EZH2 is overexpressed in CRPC and associated with poor prognosis. And mevrometostat is a selective EZH2 inhibitor. And in fact, it has shown good promise in combination with enzalutamide with manageable safety and promising clinical activity. This was a dose expansion study looking at 1:1 randomization of metastatic CRPC patients, mevrometostat versus enzalutamide, and they looked at radiological PFS, and the secondary endpoints included overall response rate from pharmacokinetics and good separation of curves, very good interesting Kaplan-Meier curve with a hazard ratio of 0.51. In solid oncology, if you get any hazard ratio of less than 0.5, we would take it. And I think this is definitely an 8-month improvement in median radiological PFS is very impressive, especially in the metastatic CRPC setting. Well tolerated. If you see, the grade 3, grade 4 side effects are very small numbers. And again, just like abiraterone, there is some interaction with food. So there's plasma exposure with the 875 milligrams of food was similar to 1,250 milligrams in empty stomach, and an improved safety profile. Again, there is a lot of dysregulation of the AKT and the PI3K pathways in prostate cancer. And one drug which is of interest is capivasertib, and it has been combined with docetaxel, and you can see plus or minus docetaxel, you can see that there is some improvement in the overall survival in the metastatic CRPC setting. And then there's the PROCATE trial, again, in patients with and without prior ARPI exposure. And there was some amount of benefit with the use of this particular AKT inhibitor with a hazard ratio of 0.57 with a statistical significance. And then a similar drug, this drug which is called as ipatasertib, which is also AKT inhibitor, and specifically in PTEN deficiency. This PTEN is measured by IHC, more than 50% loss. You can see that radiological PFS is there, and these patients also benefit with this drug. But it's early days for both these drugs. Hopefully, these drugs get into phase 3 trials, and we see FDA approval over a period of time. And again, in combination with abiraterone, there is another trial. So radiological PFS specifically seen in patients with PTEN loss, which is measured by immunohistochemistry. Again, what's more important is safety, very single digit grade 3, grade 4 side effects. And immunotherapy, now it's become a blanket therapy for most malignancies, and prostate cancer is not any exception. And we see a small number of patients who have got this MSI high, and they respond extremely well to pembrolizumab, or which is an immune checkpoint inhibitor. And this was a study from MSKCC where there was a benefit in patients with metastatic CRPC who had MSI high. And there is also some data of combining immune checkpoint inhibitors with the tyrosine kinase inhibitor. There's a drug called cabozantinib, which we use very commonly for renal cell malignancy. And if you see, the whole idea is the synergism makes a cold tumor hot. It becomes inflammatory. And that's how this immune therapy works. And it works very well with cabozantinib, which is a pan-TKI and works on several receptors. And if you see here, this was the Cosmic 021 trial looking at cabozantinib plus atezolizumab, and there was some benefit with the use of this particular drug in metastatic CRPC. And then there was this Contact 02, which looked at this combination as compared to enzalutamide or abiraterone. And if you see here, there was a PFS benefit initially. And if you see this forest plot also showed benefit in most situations. And in select subgroups, like if you see the liver patients with liver metastasis and bone metastasis, the hazards were better. So probably could consider in these kind of situations. But the overall survival is not very significant. And this was the other interesting trial which was presented at ASCO this year, the Evolution trial. Again, a radioligand therapy in combination with the immune checkpoint inhibitors in metastatic CRPC. This was a phase 2 trial. And if you see here, there was again a PSA PFS benefit at 12 months, which was 33%, almost double as compared to just using the radioligand, and which was 17%. And there was, if you see, the Kaplan-Meier curves are separating right from the beginning. And if you see the PSA, more than 50% response was also better as compared to using only radioligand therapy alone. But again, early days for this combination, doubling of the PSA PFS, and there's some benefit with the radiological PFS. And what is not very impressive is the grade 3, grade 4 side effects, which was quite significant in the combination arm of using immune checkpoint inhibitors with radioligand. Probably some tweaking needs to be done. EP is not a great drug. EP causes a lot of side effects. It's a CTLA4 antibody, and nivolumab is a PD-1 antibody. Probably some tweaking needs to be done in further trials. There's a lot of emerging therapies, radioligand therapies, like I said, actinium. They're tweaking the radioligands, especially the lutetium, changing the dose. And then there are also bispecific antibodies, the BITE antibodies, which was previously seen benefit only in hematological malignancies. Now slowly we are seeing a lot of promise in solid malignancies. Trispecific T cell engagers, CAR T cell therapy. Again, it's FDA approved for hematological malignancies, especially the high grade lymphomas and childhood leukemias. But we're seeing a lot of promise in solid malignancies and prostate malignancies, no exception. And then PSMA antibody drug conjugate, just like combining the radioligand with the PSMA for just the lutetium based, or similarly, there is a change in the payload, and there are a lot of antibody drug conjugates, especially for breast cancer and other malignancies. Hopefully, these drugs also enter the prostate cancer landscape. So that with that, I end my talk, and thank you so much for the patient listening, and thank you, Ashwin, for this wonderful opportunity. I really enjoyed giving a talk for the CME.
Thank you, Dr. Vishwanath. I think it can't get more comprehensive and extensive as this. First of all, congratulations, you've done an excellent job. And to the audience for patient hearing, we have 123 participants as of now, and I'm sure all of them have benefited from this. So I'll ask a quick question, a practical question, because we'll probably have to go through the whole presentation again to understand every nuance of the emerging therapies in castrate-resistant prostate cancer. But having said that, in your practice, when it comes to practically managing these patients, so we all know that castrate resistance is a landmark event in the natural history of prostate cancer. So, do you now with things like HRR gene mutations being studied, tumor mutational burden, deficient MMR, do you go in for a rebiopsy of any new lesions like in the lymph nodes or in the metastatic sites to kind of decide? Because many times in India, what happens is at the time of the initial prostate biopsy, we might not have gotten these done. So now, whenever it's high risk, we are getting these things done, at least the HRR gene mutations. But what is your approach to that once the stage of castrate resistance has come in?
Yeah, Ashwin, I think that's a great question. You nailed it. Not every patient of ours gets a HRR or NGS at baseline. Like you said, once the patient goes into metastatic CRPC, once the patient's disease progresses, we generally try to get a biopsy done for a couple of reasons. Get the tissue for NGS, and most importantly, also look for any neuroendocrine transformation, which can occur in 15% of the patients. And recently, we had a patient, very interesting. turned out to be a neuroendocrine. We sent it for NGS, and it turned out to be RAD51, which was a HRR gene mutation positive. Patient was not responding to any of the chemos, dosi, cabazitaxel, enzalutamide, abiraterone, nothing. And now this game changer was olaparib. And now the PSA, though it's a neuroendocrine, and now over a period of time, I'm sure all these HRR genes and BRCA is going to become a tumor agnostic approval. If you have this for any malignancy, you could treat with PARP inhibitors. And this patient has responded extremely well. And 7 months, there's a major PFS benefit, and especially for a neuroendocrine carcinoma of prostate. So it's definitely very, very important to get these biopsies done at baseline. Easily said than done, but our bioeconomics, living in a low and middle income country, as far as possible, yes.
As well. Excellent. And what about the sequencing of treatment? So mostly by the time they have reached castrate resistance, I think I would say for India, most people during their castrate sensitive phase, they are on ADT. They have received either abiraterone or enzalutamide or chemotherapy. Not everyone receives triplet. So what is your sequencing once this is done? Once they reach the stage of castrate resistance, how is your approach?
Yeah, so once they reach this stage of castration resistance, the most important, like I put the factors involved in decision making, the patient's age, comorbidities, ability to tolerate chemotherapy, and what the patient has received prior, whether the patient has received taxane, what are the ARPIs received. All these factors have to be taken into consideration, and then decide on whether, if the patient has not received any taxane and the patient is fit, we would probably go for a chemo if the disease is quite widespread and there's a lot of visceral disease. If not, go for one of the ARPIs which have not been used, and get the NGS done, see if the patient has got one of these HRR genes or the BRCA mutation combined with the ARPI which has not been used. Or, of course, now we have the radioligand therapy. We have a very good theranostic department at Apollo Hospitals, Bangalore. We generally try to get this PSMA therapy or lutetium-based therapy, so which is usually underutilized over a period. Now I'm seeing that even patients with other malignancies, solid malignancies, when the patients don't respond to the standard of care, it's good to try one of these radioligand therapies. And in combination, we have seen that there's a lot of synergism. The whole idea of making the patient, especially metastatic disease, live longer with good quality of life is combinatorial approach.
Excellent. I think with that, Dr. Vishwanath, we could go on and on with the castrate-resistant prostate cancer, because I think there's a whole army of people who are doing great research in this field. And every time we go to an annual conference, we see there's so much information that is coming in. Exciting times for all of us ahead, and probably in the interest of the patient, I hope the financial aspects as well look favorable for the patients in the time to come. Thank you, Dr.
Thank you.
Vishwanath. Excellent to have you around. So do join us for the panel discussion if you can later.
Sure. Thank you.
Okay, so that brings us to the end of the castrate resistance talk. So now, actually, the talk which was supposed to be held prior to this was Dr. Alok's talk on metastatic castrate-sensitive prostate cancer. So Dr. Alok Gupta is a senior consultant medical oncologist with extensive experience in cancer care and research, and he holds advanced qualifications in oncology and hematology. So I've known him from a long time, and my interactions with him when he was practicing in Max Hospital in Delhi. So he was doing a lot of dedicated uro-oncology work. So with that in mind, I know he would do justice to this topic, and looking forward to your talk, Dr. Alok Gupta. Take it away. His talk is on metastatic HSPC, considerations for treatment and updated evidence.
Thank you. Thanks a lot, Dr. Ashwin, for having me here. So it's a pleasure, and indeed, it was a pleasure to go through the prostate cancer management again for preparation of this talk. So yeah, I used to do a lot of uro-oncology, and I still do. Uro-oncology is one of my favorite subjects in the practice. Let me just try and share my screen. If I am not able to do, I would request help from Roshni. So can Roshni help me
Yes,
with this
sir.
slide?
Yes, sir. Our team is doing.
A very good evening to all. My talk would essentially be a journey. So I'll be taking you through how the cancer treatment, especially the metastatic hormone sensitive prostate cancer treatment, has evolved. And the journey has not been too long actually. It's only around 85 years since we have started to understand how metastatic prostate cancer evolves and how it needs to be treated. And there still is a long way to go. So around, I would say the first era, which began in the 1940s, was based on the understanding that the prostate cancer derives its signaling from androgens, and androgen deprivation in the form of orchiectomy is the right way to control this disease. So next slide, please. So in next slide, please. Uh, just a second. Yeah. So what happened was in the year 1941, Charles Huggins, who was indeed awarded the Nobel Prize for identifying that prostate cancer derives its signaling from androgens and orchiectomy improves outcome initially in animals, then in humans. That was the landmark discovery. And because of this, the way we had been treating prostate cancer earlier and after this point changed. And over next 60 years, it was essentially androgen deprivation therapy alone. And the research largely focused on eliminating orchiectomy as a treatment. In fact, we had androgen, in fact, we had medical management to substitute orchiectomy in the form of agonists, so LHRH agonists. So we have three of them currently available. And then we had antagonists. So antagonist, which came later on, they with some probably some advantages over agonist. So largely the work from 1940 to up to 2000 largely focused on devising various mechanisms of androgen deprivation therapy with some oral molecules. However, we understood that these patients they do progress to a castration resistant state, and there was an unmet need to develop more molecules which can be effective in the castration resistant state. And to that effect, chemotherapy came into picture. So earlier we were using different drugs, say for example mitoxantrone, but the real big breakthrough came with the discovery of docetaxel and the usage of docetaxel. So can we move on to the next slide, please? Yeah, just move on next 2-3 slides. Yeah. Yeah, next slide, please. Yeah. So what happened is from 2000 to 2014 onwards, there was a plethora of drugs, both on the chemotherapy front and on the non-chemotherapy front in the form of newer anti-androgens that essentially improved upon the outcomes of patients who developed castration resistance. So if I were to say in the year 2000, the time point or the median overall survival for a metastatic prostate cancer used to be somewhere around 2 years. But with the availability of these molecules, which is docetaxel and then cabazitaxel and then abiraterone enzalutamide, the overall survival improved. Next slide, please. And each of these agents actually added somewhere around 4 to 5 months in terms of overall survival. So this table enumerates the usage of these drugs in the resistant setting so as to improve the survival outcomes. Next slide, please. Next slide. Now, this improvement of
I think
to a
Dr.
resistant state. And we find that the median time point of this transition was 11 months. Now, before the availability of this drug, this orange line, the orange line which reflects the overall survival, it used to be another 10, 11 months. So the median survival used to be around 2 years. However, with the advent of these molecules, the docetaxels and the cabazitaxels and Abira and Enza, the median survival improved to around 42 months. So what we were finding in the year 2014 is that these patients were living longer in a resistant state of the disease. So it was only 11 months in the sensitive state and another close to 2.5 years in the resistant state. So roughly reaching around 3.5 years of median survival. Now, the idea of the research at that point in time in the trials was to shift both these curves towards the right. We moved the green curve that is transitioning from sensitive to resistant state towards right, and in turn also transitioning the orange curve, which is the survival more towards the right. Now, to this effect, can we move on to the next slide? Now, in order to improve upon these survival outcomes, the next slide, please. So we started using these drugs in the sensitive setting. Next slide, please. So then came this era from 2015 to 2020, and I've named it as the era of sequencing. So we knew that there are certain drugs which are effective in CRPC state. How about testing these drugs in the hormone sensitive state? And 2015, the docetaxel data came up, and it for the first time it showed a quantum improvement of more than a year in the overall survival in metastatic prostate cancer. So if you remember, in the CRPC setting, the same drug is leading to improvement to the tune of 3 months, 4 months. But when the same drug has been used in the sensitive setting or hormone sensitive space, the quantum improvement suddenly jumped. And this was probably one of the happiest moments for medical oncologists. Why? Because they were getting involved in the management in the hormone sensitive setting as well. Next slide, please. So three trials came one after the other in this period, starting from 2015. The first was the JTOC-15, which compared patients again metastatic prostate, docetaxel plus ADT versus ADT alone, and with a primary endpoint of overall survival. Next slide. And this trial showed that numerically there was a 5-month improvement with the in the overall survival with the addition of docetaxel. Next slide, please. Yeah, but the more convincing data, next slide please, came from the landmark charted trial in the year 2015. And it was after the availability of the study and the data, we started using docetaxel in our day-to-day practice. Next slide. So in this trial also, patients with metastatic prostate cancer were randomized to receive docetaxel along with androgen deprivation therapy versus ADT alone. There was a predefined stratification based on the volume of disease, whether it was a high volume disease or a low volume disease. Next slide. And overall, in the intention to treat population, what we found at an earlier analysis was that the docetaxel led to a significant improvement in overall survival. You can see that the median OS is 57.6 months compared to 44 months. Now, I want you to recollect the median OS which I showed in the era where a combination was not used. So if we go back to that slide, we would know that the median OS was reaching around 42 months. Now, for the first time, the median OS is crossing that landmark and reaching up to 5 years. Next slide, please. And it was because of this quantum improvement of around 40. However, next slide, please. Yeah, next. Next. Yeah. So, however, on a longer term follow-up, we found that it was only the high volume disease patients who were deriving benefit in terms of OS. and the low volume disease, these patients were doing well anyhow, and the improvement in survival with the addition of docetaxel was not significant. Next slide, please. Although there is improvement in OS, but it comes at a cost of slight increase in toxicity, and more specifically, the neutropenia and grade 4 neutropenia was to the tune of 9% in patients receiving a combination strategy. Next slide, please. Next slide. Then the third study, which established the role of docetaxel, was the STAMPEDE. The STAMPEDE also, it was a multi-arm study, but the arm which compared docetaxel along with androgen deprivation therapy and compared it with ADT alone had similar outcomes. Next slide. And this also showed a significant improvement in OS, with the median OS reaching 60 months in the combination arm versus 45 months. So essentially replicating what has been shown in the J215 and thereafter in the charted trial. Next slide. Next slide. Right. So at the end of 2015, we had this data with us of these three trials showing improvement in OS, and this is how we were practicing from 2015 to 2017. Next slide. So this is a meta-analysis of these three trials. The overall there is improvement, 9% absolute improvement in survival at 4 years. Next slide. So what we were able to do, we were able to shift this green curve from 11 months towards right, and we were able to shift the OS curve from 42 months to close to 5 years, that is around 60 months, by using docetaxel. Next slide. Now, in the year 2017, another interesting thing happened, and uh, so there were more molecules which came over next few years, and abiraterone was the first of them, which challenged the docetaxel usage in the hormone-sensitive setting. So, two landmark articles: one is the Latitude trial, and the other is the Stampede with the abiraterone arm. They were published back to back in the same edition of NEJM in 2017, and they opened newer avenues by which we can treat these patients. Next slide, please. And especially for those patients who would not want to be treated with docetaxel. So addition of abiraterone led to a significant improvement in OS. Next slide. In the Latitude trial and also in the Stampede trial. So both these trials showed that there is a significant advantage of adding abiraterone along with ADT compared to ADT alone. Next slide. So by the end of 2017, there were these 4 practice-changing trials which were available, and now we had started to offer our patients. We started giving them 2 options: whether to go for docetaxel, which is a finite period of time treatment. We need to give 6 cycles, and then you continue on ADT alone. Or on the other hand, there is a chemotherapy-free option, which is abiraterone. However, you need to continue abiraterone until you develop castration resistance. But the magnitude of improvement in OS, which was demonstrated in these trials, especially in the earlier part of these studies, it was essentially same to the tune of 14 to 15 months OS improvement. Next slide. How to select between these two? Now, there was hardly anything to select. So Stampede, since had both the arms, it compared, but the OS was essentially the same. The hardest endpoint for metastatic prostate cancer patients, which is overall survival, was similar whether you use docetaxel or abiraterone. Next slide, please. Now, 2018 onwards, between 2018 and 20, more studies started coming up, and there was a focus on the newer anti-androgens, especially the apalutamide, enzalutamide, and darolutamide. Now, these have novel mechanisms in addition to what we have seen with bicalutamide. So these have novel mechanisms of action, and these drugs proved their effectiveness in the castration-resistant state as well. So it was only logical to test these molecules in the hormone-sensitive setting as well and see whether addition of these to ADT led to any improvement. To this effect, few trials were conducted, phase 3 very large randomized trials. Next slide, please. So one of them, which included enzalutamide, is called the ARCHES trial. More than 1,000 patients were included. Somewhat similar trial design, enzalutamide plus ADT versus ADT alone, led to a very significant improvement in overall survival with a hazard ratio of 0.6. And the other trial, which included apalutamide along with ADT, the hazard ratio is again 0.65. So similar hazard ratio, similar quantum of benefit by adding newer anti-androgens to ADT, establishing the role of these drugs along with abiraterone and docetaxel in metastatic hormone-sensitive prostate cancer. Next slide, please. So by the year 20 multiple options which could be combined with ADT. ADT alone was no longer a preferred option, and we were reaching a survival of close to 5 years, around 60 months. However, we needed so 60 months is not enough. We need more treatment options. Can we prolong the survival even further? To this effect, a lot of work has been done and as has been enumerated in the previous talk in the CRPC setting. But at the same time, even in the hormone sensitive setting, the work continues to happen. And we have tried treatment intensification in this era, which started from 2021 and it still continues. So by intensification, we mean rather than doublet, can we use a triplet? And did addition of triplet led to improvement in survival outcomes? Now, to this effect, few trials have been conducted. Next slide, please. Which have combined. Next slide, please. Yeah, so which have combined the docetaxel along with anti-androgen therapy along with abiraterone in one trial. So this is the PEACE-1 trial. Again, a very large randomized trial, close to 1,200 patients with metastatic prostate cancer included, stratified based on high volume, low volume. One arm received triplet of abiraterone plus docetaxel plus ADT, and the other arm, it is docetaxel plus ADT. So the standard of care was docetaxel plus ADT at that time and not ADT alone. The other trial is the Erescence trial, which was similar. Only difference was it used darolutamide in place of abiraterone. So it's an anti-androgen darolutamide plus docetaxel plus ADT versus placebo docetaxel plus ADT. Next slide, please. Now, these trials had a point of PFS and OS, but OS being the hardest endpoint, the trial met its primary endpoint. So PEACE-1 showed that using a triplet led to improvement in OS, with a hazard ratio of 0.75, and even the Erescence trial showed that there was improvement in overall survival with a hazard ratio of 0.68. Next slide, please. Now, further subgroup analysis also suggested that the magnitude of benefit derived by patients who had high volume disease is more in triplet regimes. And there was no significant improvement, at least no statistically significant improvement in OS for patients who had low volume disease. Next slide, please. And obviously, if you use triplet, it will come at a cost of increased toxicity, most of them well manageable. And over last 2 years, we have also evolved our practice where for selected patients, we use triplet regimes. Next slide, please. So in PEACE-1, there was increased incidence of liver function abnormalities with abiraterone. In Erescence, there was increased incidence of hypertension and so on and so forth. So, however, the point to emphasize is that we have now moved beyond a median overall survival of 60 months by using a triplet strategy upfront. That triplet strategy is not for everyone, But for most or for a lot of our patients who are candidates, they should be receiving a triplet strategy. Next slide. So this table just enumerates the number of drugs which have been shipped CRPC state to a hormone sensitive state. Choosing between them, it's a both easy task and a difficult task at some time. But yeah, we do it all the time in our practice. Now the bigger question is a doublet versus triplet, and we navigate in our day-to-day clinics how to incorporate triplet in as many patients as possible. Next slide. So this is where we stand in 2025. ADT alone might not be the best option. Doublets, there are many options which can be combined with ADT, including docetaxel, including abiraterone, and then enzalutamide and apalutamide. And now we have even triplets where darolutamide along with docetaxel is combined with ADT versus abiraterone docetaxel ADT. So a lot of options. Next slide. And lot of hard data. So each of these options come with lot of backing, lot of hard data, 1200 patients, 1300 patient studies. And this table enumerates all those practice changing trials which have come over last 10 years, and because of which we have been able to prolong the survival from that 42 months to more than 5 to 6 years now. Next slide, please. So to conclude, I would say that the journey of metastatic hormone sensitive prostate cancer has evolved over last 85 years. Initial 60 years was largely the era of androgen deprivation therapy. Both medical and surgical ways were evolved. From the then the next era was the era of discovery, where a number of numerous agents, including chemotherapeutic drugs and newer anti-androgens, were discovered, largely used in CRPC setting, but it led to improvement in overall survival. Then came the era of sequencing, where we started using the same drugs in the upfront hormone sensitive setting with the objective of increasing the OS. And most such strategies worked, and we improved the OS from 42 months to 5 years. And over last 5 years, we have further intensified our treatment in the hormone sensitive setting, where we use triplets and triplets for certain select patients, and it had further improved upon the survival outcomes. Thank you.
Thank you, Dr. Alok. That was definitely extensive. I know it was a very voluminous topic that you had to take up, but I think it serves as a good synopsis of everything that's happening in the metastatic castrate sensitive space. Thank you so much. Actually, we are actually in a Saturday evening, many faculty members are having to head out. So without, I would probably bother you with some questions on the chat box. I think you also have to emerge, but point is well taken that doublet versus triplet is definitely a consideration in this day and age. Okay. And one question, I'll take one quick question from one participant. Dr. Deen Dayalan asks, what would be your recommendation for otherwise fit low volume metastatic castrate sensitive prostate cancer? Otherwise fit low volume metastatic castrate sensitive prostate cancer. Can you hear me, Dr. Alok? I think we've lost Dr. Alok. There he is. Yeah.
Yeah. So, right. So ADT alone would not be an option. ADT plus something, and that something can be either enzalutamide or abiraterone. So difficult to select between the two, but yeah, there are options, and we should be selecting between them. Certainly, for a low volume disease, I would refrain from using a triplet at this point.
Thank you so much. I think some of these points could be clearer down the line. We have some panel discussions lined up. So without further ado, thank you, Dr. Alok. Moving on to a hot debate now between surgeons and radiation therapists. So from the Euro oncology side, we have Dr. Tushar Aditya Narayan, a dynamic uro-oncologist from Max Hospital, Saket, an excellent surgeon and an excellent academician as well, who has, I'm sure he will do justice to what the urologists have to say. And Dr. Shika Aldar, she is the chairperson for radiation oncology at Sir Gangaram Hospital. So I think we won't delay them further. We'll get into this debate, which is surgery versus radiation therapy for high-risk localized prostate cancer. Take it away, Tushar.
Hi, good evening. Thank you so much, Dr. Ashwin, for this opportunity, and good evening to all of you. I'll start sharing my screen if I may. Yes, can you see my screen?
Yes, we can.
Perfect. So thank you for this opportunity, and thank you for giving me this debate. This is a century-old debate, probably, and I have heard my mentors, my seniors debate this. I have debated this, and we have never come to a conclusion. And today I've been set up against a very experienced and renowned radiation oncologist of our country. It's not fair, but I'll try my best to stand up to her and put my points across that surgery, yes, is an option in locally advanced or high-risk prostate cancer. So we all know what high-risk prostate cancer is. EAU and NCCN almost are the same. NCCN also gives a very high risk. Basically, that's T3, T4, pre-PSA more than 20, and Gleason grade 4, ISUP 4 or 5. So now coming to the treatment options. So the different treatment options that come to our mind, I've listed all of them down. ADT alone is not an option. EBRT alone is not an option. ADT, that is long-term hormone therapy plus EBRT, is a standard category 1 recommendation. That's long-term hormones plus radiation. Neoadjuvant hormone therapy plus radical prostatectomy, nowhere in the guidelines, but it's coming up in a big way. And radical prostatectomy in a multimodality setting, that's plus minus adjuvant therapy, that is again a category 1 recommendation. So I'll go through the guidelines. NCCN says if it's a high or a very high risk prostate cancer, you give radiation therapy plus hormone therapy plus abiraterone therapy for very high risk patients. At the same time, it says you can also do a radical prostatectomy plus pelvic lymph node dissection. One point that I want all of you to focus on is in the surgery part, they just mention the surgery. In the radiation arm, they say you give radiation, you give hormone therapy, and you give abiraterone therapy. So the debate here is comparing oranges to apples. If you have to compare apples to apples, it should be radiation plus hormone therapy versus surgery plus hormone therapy. So we'll see how it goes further. So before I start off, this is one of the latest papers that is going to be published in August 2025. It's a retrospective study. There are no randomized control trials between these two arms. So they had about roughly 1,200 patients equally divided amongst both the arms, and propensity matched. They showed that the cancer control outcomes, the metastatic free survival, cancer specific survival, and overall survival were same in both the arms. So take home point from this study: surgery and radiation plus hormone therapy has the same outcomes. Now, why is there a debate? There is a debate because radiation oncologists feel that surgery has poorer functional outcomes. That's urinary incontinence, erectile dysfunction, delayed recovery, and it has poorer oncological outcomes. So these are the main 2 points that is used against surgery: poor cancer control, poor functional outcomes. So let's see. I'll address each one by one. We are in the era of robotic surgery. Poor functional outcomes was a thing of the past, probably 10 years ago when you were doing open or laparoscopic surgery. The robot, especially the latest Da Vinci robots and all of that, has immense technology which gives us the power to do very fine surgeries, which in turn results in better functional and oncological outcomes. The margin positivity rate has gone down. The functional rates have improved. How have they improved? The continence rates have drastically improved. Global data shows that for high-risk prostate cancers, 95% of or 90 to 95% of patients regain their continence by 3 months of time. Surgical outcomes are better. The hospital stay now is about 1.5 days, as against 7 to 10 days in an open surgery. The average blood loss is 50 ml, and major complications is 5%. These are all from major studies. Surgery also provides us with a detailed tissue. The whole prostate is removed and sent for biopsy, where we can run the IHCs, the lymph node status, the margin status, which can help us plan or tailor the adjuvant therapy later on. Now I'll be going in for some studies which have been published by the surgical groups. This is from the group of Alexander Motry. They have a very large series of radical prostatectomies in a high risk setting, and they showed that the clavin-dido complications were acceptable. 3-4 grade complications were just 3.2. 1 and 2 were 5.3 and 4.3. And also, they also have mentioned about the BCR and the overall survival, and the BCR survival rates at 3 years was 63.3%. That means 63.3% of the patients did not have a BCR. Mind you, this is only high risk prostate cancer, and clinical recurrence free was 95.8%. Coming to long-term functional outcomes after radical prostatectomy, multiple studies are there which have shown that good urinary incontinence and even good potency is possible after a radical prostatectomy. We would believe that we would do a wide excision for these patients. We would not do a nerve spare, but still these studies have shown that erections do come back in these patients and they continue to improve over the next 3 to 5 years after surgery. This is another study which talked about the functional outcomes in 1,300 patients, and it had similar results. Now, coming to some systematic analysis on the oncological outcomes. We talked about the functional outcomes. Now, let's talk about the oncological outcomes. There are three major systematic reviews which have evaluated the cancer specific survival and the overall survival. And you'll be surprised to see that most of these studies are in favor of radical prostatectomy, and these are all for high risk diseases. Obviously, there are some studies that favor radiotherapy also, but most of them are favoring radical prostatectomies. Another systematic review and meta-analysis, this was in 2014, I guess, and here also they concluded that the cancer-specific mortality rates were better with radical prostatectomy compared with radical radiotherapy in a localized high-risk prostate cancer. All of these studies in the subset analysis said that the biochemical recurrence is better in the radiation arm, but the long-term cancer-specific survival, overall survival, is better in the surgery arm. This was another systematic analysis, but this was not a very good one because it had only 3 studies. But they also said that radical prostatectomy is better in patients with high-risk prostate cancer. So why is there a debate? I'll come back to that slide. The 2 main reasons that the radiation oncologists cite. Now I've disproved both. Poor functional outcomes, no more with robotic surgery. Robotic surgery allows very good functional outcomes. Poorer oncological outcomes, the systematic review and the meta-analysis have disproved it. Now, what the radiation oncologists don't talk about when they talk about hormones and radiation therapy when counseling the patients: the adverse events due to radiation therapy, the adverse events due to hormone therapy, the prolonged duration of therapy, which is 2 years at least for hormone therapy and 4 to 6 weeks, depending on the fractionation of EBRT, compared to 2 days for a radical prostatectomy in the hospital. And what happens if there is a biochemical recurrence after radical radiotherapy? Talk about salvage surgery. I'm sure all the urologists in this panel who are doing robotic prostatectomies would know what a nightmare salvage surgery is. I don't get a good sleep the night before I'm planning to do a salvage radical prostatectomy after EBRT. Adverse events of radiation therapy, there are long-term geotoxicity, urinary retention, lower urinary tract symptoms, more of irritative symptoms, radiation cystitis, recurrent hematuria, probably need for cystectomy because of these symptoms, and long-term GI toxicity, that's radiation proctitis. All urologists would agree, management of hematuria is a nightmare because of radiation cystitis. And it doesn't happen at predetermined intervals. It can happen anywhere, 3 years after radiation, 5 years after radiation. And the treatment, whatever you do, it's unpredictable. It can come back. You've done a good cystofulguration. 1 week later, the patient comes back that he's bleeding again and questions what you've done. I myself have done 2 cystectomies for patients who had intractable hematuria. One had intractable hematuria, one had severe LUTS because of the contracted bladder due to radiation. Obviously, we know the long-term adverse events of hormone therapy also. This paper evaluated the long-term hormone therapy adverse effects along with radiation toxicity. So there was about 11% more than grade 2 rectal and urinary toxicity. And the hormone therapy obviously had its own cardiovascular events. So to summarize, there is no published randomized controlled trial at this point of time which directly compares radical prostatectomy versus EBRT plus ADT. Meta-analysis have shown that there is better cancer control and BCR and metastasis-free rates, as I said, with EBRT and ADT. It is even better when brachy boost is added, but I'm not sure how many radiation oncologists are adding brachytherapy to radiation therapy with hormone therapy. But however, the overall survival and the cancer-specific survival is better with radical prostatectomies. And obviously, if you add adjuvant therapy, which is hormone therapy, which is the standard in the radiation arm, it becomes even better. Side effect profiles differ. This is likely a major decision factor, I think, in decision making. There is one randomized controlled trial which is ongoing. It's going to complete its accrual into a 2026. That's the SPCG15 trial. That's a randomized controlled trial between radical prostatectomy and hormone plus radiation therapy. All the guidelines say both options are available. Key points: radical prostatectomy is preferred in younger and healthier patients. Radiotherapy plus long-term ADT or trimodal RT is preferred in patients, obviously, who are unfit for surgery. Decision must be multidisciplinary and it should also be a shared decision making with the patient. So to summarize, RARP in a multimodality setting and EBRT plus ADT, both are standard treatment options for high-risk localized prostate cancer. Oncological outcomes are similar, but the side effect profiles are different. So this is what we need to discuss with the patient. Some studies have done a subset analysis and then showed that, and I agree with this, patients who have a PSA more than 50, Gleason 5 plus 5, they do better with radiation and hormone therapy. I agree. In these patients, radiation scores over surgery. As I said, this should be a shared decision making, and all high-risk cancer patients falling in the high-risk category should not be blindly declined the surgery. It should be a shared decision making. My last point before I sign off is, if we have to do a fair comparison, it should be surgery plus hormone therapy versus radiation plus hormone therapy. It's unfair to compare only surgery with hormones and radiation therapy. And we should always remember what happens if there is a BCR. It's easier to do radiation after a failed surgery rather than a surgery after EBRT. Real world fact, I have done a robotic radical prostatectomy for fathers of two leading medical oncologists in India, and both had high risk disease. One received ADT because of positive notes, other is on surveillance. Thank you. Thank you for patient hearing.
So point is very well taken, Tushar. I think you have excellently covered what surgeons want to put forward in every meeting. But Dr. Shikha is also, I'm sure she has some great points to make. So just hang around for the rebuttal if you can, Dr. Tushar.
Sure. I'll be here. Yes.
Yeah, waiting for your presentation, Dr. Shikha, ma'am. Please go ahead.
Can you hear me?
Yes, ma'am, we can.
Roshni, can you please put up my slides? Thank you, Dr. Tushar. Like you made your point about surgery, and you said they are apple and oranges. I agree, definitely agree. But I would not say that it's only radiation or surgery. We can choose the patient. Now it's the era of customized treatment, not just we should treat this patient with radiation, or we should, surgeon should say we should do radical prostatectomy, and radiation should say that we are going to give radiation therapy. So again, just a revision on the high risk points. So we have two classification. One is NCCN, which Dr. Tushar has mentioned. Another is D. Amico et al., where they have included even clinical stage 2C, that is involvement of both the lobes. Next slide. So if we have to do at least in high risk prostatic cancer, if you are doing a radical prostatectomy, it is the high risk is about 15% of all diagnosed cases, and they have increased risk of biochemical recurrences, metastasis, and mortality. And as Dr. Tushar has said, there are three different options: radical prostatectomy, radiation therapy, and systemic therapy like hormonal therapy and chemotherapy. And now with innovative blood and tissue-based markers, they are being researched to guide our therapy selection. So radical prostatectomy and RT is advocated in high-risk patient, but we should decide the timing. Adjuvant radiotherapy, though it improves biochemical failures, but it is underutilized because of over-treatment concern and dual toxicity. The meta-analysis of patients with radical prostatectomy when they were balanced with adjuvant radiation therapy or with delayed salvage therapy, they found that there was no difference. So the current approach is for early salvage radiation therapy, though long-term outcomes are further study. As Dr. Tushar has said, they have only radical prostatectomy and we have radiation as an ADT. That is not true. There is radiation for patients who after radical prostatectomy. So what are the options with radiation therapy? Those who have more than 5 years of survival, I'm mentioning it is as more than 5 years because all the patient who come to us are old or with comorbid condition. So their first selection bias is there right from the beginning. So what are the options? EBRT with ADT, EBRT with brachytherapy. If nobody does brachytherapy, very few people do brachytherapy here, but one must understand we have SBRT boost. This is a new thing in the presently which is being used. Sorry. And previous slide. Can I have a control of the slide, this thing? So for patients who have less than 5 years, the three can be done: observation or ADT or EBRT. Next slide, please. So as we have to, the only problem, the negative point about radiation therapy is a prolonged treatment. Earlier, it used to be about 7 to 8 weeks, but slowly with hypofractionation, we have reduced the timing to about 4 weeks to 6 weeks, depending on if you are treating the pelvis or not. And this has shown equal results with acceptable toxicity. So should we treat the pelvis? As in radical prostatectomy, one has to decide whether we should do a radical pelvic node dissection. Here sometimes we have to decide whether to treat, because that depends on the patient general condition and also the comorbidities. So there are 2 studies which have shown that if you are treating the RTOG 9413, which has 4-arm study, one with ADT alone, with concurrent ADT versus adjuvant ADT, prostate only tree RT versus whole pelvis RT. They found that 4 years progression-free survival in prostate only RT versus whole pelvis, there was significantly difference in progression-free survival, 47 versus 54%. And this is the POP RT trial, which was done in our TMH. And this has shown all the parameters like biochemical failure, free progression survival, distant metastasis free survival, or disease free survival, always superior with pelvic radiation. And patient who received pelvic radiation had a 13% recurrences versus 52% who did not undergo pelvic radiation. Next slide. So what is the evidence of long-term ADT? As Dr. Tushar was mentioning, there is so many side effects and all that, but we have to see the benefit. So these 3 trials have definitely shown a much, much better survival, whether it is overall survival or it is a disease-free survival. Next slide, please. So this is a recent review of this thing, but I just mentioned it to show that the technique of radiation has become very, very important in getting a better result and as well as lesser toxicity. The use of image-guided intensity modulation as well as incorporation of brachytherapy and SBRT here, they have not mentioned, has led to safe radiation dose escalation and reduced risk recurrences. Clinical trials have defined the role of pelvic radiation therapy, the role of stereotactic ablative radiotherapy, and optimal duration of sequencing of ADT combination with radiotherapy. This is redefining the role of surgery in this cohort. And with the MR, multiparametric MR and molecular imaging and genomic classifier, we have a new era in patient for risk stratification and treatment tailoring. Next slide. So coming to our recent techniques, this is the conventional radiation where we see the whole pelvis is getting a higher dose, whereas here in intensity modulated radiotherapy, you have to know that intensity modulated radiotherapy is a little labor intense, because we have to mark each and every area in the area to be treated, as well as the normal tissue where we have to avoid the doses. So here you can see the whole pelvis, which is getting a lesser dose and a booster dose to the prostate. Next slide. So this is a stereotactic radiotherapy, which is mostly used in low risk or intermediate risk. This is to compete with the robotic prostatectomy, because here the treatment is over in 7 days. So the dose given is very high, that is 35 gray in 5 fraction. And so they hold, and but in high risk patient, we can use it as a booster, whether after say 20 days of radiation, it can be finished in 3 days. And the other important thing is image guided radiation therapy, which is very, very important, because of the bladder and the rectal filling, they may be changed in position of the prostate. So daily one needs to use a bladder filling and rectal emptying protocol, and do an onboard imaging to see everything is matching, the bladder, the rectum, as well as the prostate. Otherwise, the internal movement will cause the radiation to be given elsewhere than the intended target. Next, please. So what are the complications? As he has mentioned, these are not anymore, but when you compare with radiation therapy, definitely urinary symptoms like incontinence and strictures is much higher with surgery, which is very, very little with radiation therapy. And erectile dysfunction, though they mentioned there is a moderate gradual onset in with radiation also, but this I will contribute more because of the age-related and comorbidity rather than the treatment. Bladder irritation is definitely more in radiation therapy, during radiation, also after, because of the dysuria and urgency. And hematuria, again, late hematuria cystitis may be there, as Dr. Tushar has as mentioned earlier, but now again, as I say, with this IMRT and IGRT, it is becoming less and less. Bowel toxicities, again, when we are treating with the conventional radiation, there was much more higher. Now it has come down to 2%, not 5 to 10%. Fistula, fatigue, and lymphedema, they are there, but they are very rare. Next slide, please. So coming to the, this is the first time when they had published in 2000 comparing intensity modulated radiotherapy with radical prostatectomy. So they had, it is a retrospective analysis, 993 patients in radical prostatectomy versus 207 patients in IMRT. So this is all grouped together, not the high risk patient, but they were intermediate risk group also. But you can see that radical prostatectomy had much younger patient than the IMRT group. So, but even with that, there was no difference in cause-specific survival between the two modalities. Next. So this is a systemic meta-analysis of 70 studies, 1 randomized and 16 retrospective. They evaluated overall survival with prostate-specific mortality and non-prostate-specific mortality. Radical prostatectomy was associated with improved overall survival and both prostate-specific mortality and non-prostate mortality. Biochemical relapse were similar in both arms. So this meta-analysis showed an RP offers a better overall and cancer-specific survival in high-risk patients. Next, please. So this is a smaller retrospective analysis of 180 patients. I bought this because they have here there was a higher biochemical relapse in radical prostatectomy compared to the external beam radiation, and the results were even there was no difference in the survival. Next slide. So this was published recently in 2025. This is an analysis of 2 randomized trials with comparing radical prostatectomy with radiation therapy. Next slide, please. So here, it was due to inherent difference in the biochemical recurrence after radiotherapy versus radical prostatectomy. Inverse probability of treatment was weighed, cumulative incidence of distant metastasis as the primary endpoint, and considering death as competing events. So there were 1,200, nearly 1,300 patients, and with similar median follow-up. As you can see, radical prostatectomy patients were much younger and with a lower baseline PSA. And at 60%, more than 60% received salvage radiation therapy.
Ma'am, if you could please summarize your...
Yeah, sorry. Next slide, please. So here, as he was mentioning, they have compared with only with radical with ADT and radiotherapy, but here they have compared with radical prostatectomy, ADT, and docetaxel, and though the radiation group has shown a much better recurrence-free survival compared to radical prostatectomy. Next slide, please. Because I don't have control on the slide, I'm losing time on that. So the ISMO recommendation is extended for very high risk and high risk is external radiation therapy with ADT and abiraterone and prednisolone in very high where when there is a pelvic node positive or PSA is more than 40 nanogram per ml. Next slide, please. So the European guidelines says we can use any of the modalities provided we explain to the patient thoroughly and the side effects. So this is radical prostatectomy plus minus adjuvant radiation therapy with ADT, either doing hypofractionation with IMRT and IGRT, SBRT or brachytherapy boost, and of course ADT and androgen therapy inhibitors, others like abiraterone and enzalutamide also can be used. Next slide, please. So what are the emerging approaches? Genomic classifiers to personalized treatment, addition of novel agents like abiraterone, and at very high risk cases, and SBRT is being explored in trials for selective cases. Next slide. So comparing both, yes, surgery has gives us a more definitive pathology, may require adjuvant radiation therapy, higher urinary incontinence and stricture, higher erectile dysfunction, best for younger. You have to note this, it is best for younger patient and healthy men. Radiation is non-invasive, lower incontinence risk, higher GI, which is coming down with modern techniques, moderate erectile dysfunction. This is, again, I feel it is because of the age and comorbidity, not due to the treatment, suited for older and comorbid patients. So here the patient selection is initial stages only is wrong. So comparing two modalities is very difficult to say which is better modality. Thank you.
Thank you, Dr. Shikha, for that, for the points you made. Dr. Tushar, would you like to rebut for a minute at any arguments
I think I don't. There's no requirement for a rebuttal because ma'am and I are on the same page. We showed that all treatment options are available, and I think it's a shared decision making.
I think it was the best talk of radiation oncologist on locally advanced prostate cancer I've heard ever. Very balanced talk, and madam showed actually that, where surgery is better and where radiation is better, and we all, I think, more of us have a consensus on that. So thank you, ma'am, for a wonderful talk.
Yeah. Okay. So I would, ma'am, would you like to rebut any other point? You made your points. I think you've given a very balanced approach. I think shared decision making is the take-home message for all people present here. I think even as surgeons, we know very well then when it's a very advanced, locally advanced prostate cancer, for example, when the PSA is very high, more than 40 or 50, nodal positive, and there could be T3B. These are the things when there's a combination of factors. We would definitely involve the radiation experts, and if every case can be put through a tumor board, I think, and with the patient's wishes kept in mind, I think we would provide the best treatment. I think
I can make it a point. We would never irradiate a younger patient. That much I can tell you that because because there is always a salvage treatment even after radical prostatectomy. But the age, when do we take it for radiation, which is the cutoff limit? That is the most important. Whether is it 60 or whether it's 70 or 80, when do you stop doing radical prostatectomy? That the surgeons have to answer us.
So, yeah, I think one very valid point would be the lifespan is increasing. Not only the lifespan, we have healthy men at 75 to 80 who have no diabetes, no blood pressure, no hypertension, no coronary artery disease. Those are the centenarians. Okay, definitely. I think all of us surgeons here have operated on patients who are on the, on the other side of 80 as well, provided the case selection is very important now. But your point is very well taken. We may have a 60-year-old with a life expectancy of 5 years. We may have an 80-year-old with a life expectancy of 15 years. I think
True.
it's all these factors kept in mind before we decide for the patient. Thank you very much, Dr. Tushar and Dr. Shikha ma'am, for your wonderful debate. I think in the interest of time, we'll just go quickly to the next talk. Dr. Harshit Garg, who has, who's a uro-oncologist from Max Hospital, Patparganj and Vaishali. He is going to give a talk on risk stratification and prostate cancer impact on outcomes. His talks are always very informative. At the same time, they are very entertaining. So please take it away, Dr. Harshit.
So I think I just switched off my video, but I think you guys can hear me.
Yes, we can.
So first of all, thank you, Dr. Ashwin, the entire, Oncology Update, committee for having me. I apologize for, coming in, late. I just had planned everything very perfectly, but suddenly got a call from GI surgery OR that, somewhere the ureter is getting stuck. And so I had to get into the OR and then things just, didn't turn good. So, but thank you and I apologize. And I guarantee I'll save your 5 minutes. They show me a clock of 15 minutes, but I'll try to wind up in 10 minutes because a lot of things have been discussed.
Yeah.
So risk stratification in prostate cancer, you start with 63-year-old guy, 46-gram prostate, bilateral nodules on the DRE, PSA of 24. We have done a biopsy already, Gleason 4+4 disease. So, this is our index case. We'll just take it forward and to see how we do the risk stratification. So, we all have learned this, how the series of clinical, prostate progresses from, non-metastatic and then metastatic and then castration resistant. So why are we talking so much? Because in one line, I'll say, it has a low malignant potential overall. And, single modality can actually cure it. But then there is a role of multimodality treatment as well. And we are all worried about high risk or advanced cancer because they are, somewhere where we actually have to intervene, nicely. So these are the various prognostic factors we have all discussed: stage, PSA, Gleason. I know we have these core formulas to calculate about the lymph node involvement, seminal vesicle involvement, and extracapsular extension. So this is the very historical data in 1998. The 15-year risk of dying from cancer in relation to Gleason score. And when you say, at that time, if you have Gleason score 8 to 10, you're gonna die 60 to 80% chance with the cancer. And this was, cancer specific mortality was 93%. But if you have a score which is, less than 5 or 6, this range is around 10% only. So that is the message from this slide. So TNM classification, the standard classification which AJCC gives, there was things it was limiting in prostate cancer prognosis because it does not include Gleason score or the PSA. And Dr. Amico, he came up, he's a radiation oncologist, but he came up, with a risk stratification, which essentially laid the foundation of all the NCC and EAU guidelines later on, was the clinical stage, Gleason score, and the PSA. And then, we had more discussions on the extent of biopsies. So, we'll not go into so much of literature that we're talking only that much, but we all know what is T1A, B, and C. Just to quickly, T1A, if a patient has been undergoing TURP and less than 5% is the chips are malignant or more than 5%, it became denoted. And then C is a renal biopsy. Again, T2A, B, C, which is more common. Single lobe, less than half, more than half, and both the lobes. T3A is extracapsular, T3B is seminal vesicle, T4 is adjacent structures. Gleason, I think already discussed by the pathologist. I missed her talk, but I'm sure she would have discussed Gleason in detail. So this is what DMECO was: low, intermediate, high risk, which we're all learning, all following T1A, T2A. Gleason score less than 6 or equal to 6, PSA less than 10, Gleason 7, PSA 10 to 20, T2B, and more than T2C, Gleason 8, and PSA more than 20 is high risk. So that is a basic, that we all know. And now we are going to build up from here. So this was the PSA failure rate at 5 years. If you are low risk, it is less than 25%. If you are intermediate, you are 25 to 50%. And if you are high, you are more than 50%. So this is a gross idea in 5 years. And then you have NCCN risk stratification, which I will share with you this complicated slide, which just, I know will drag off your attention. So I'll just focus it. So let us talk very low risk and NCCN. This category is here, refined category introduced in last 5 or 7 years. The simple reason is that, it demands a lot of active surveillance. It might not be, it's just a prostate cancer, which is there, but which might not cause a lot of harm. So T1C disease, that is detected on needle biopsy, Gleason grade 1, PSA is less than 10, and then all the 3 plus, we have less than 3 biopsy scores positive, and each core has less than 50% cancer, and PSA density is less than 0.15. A very rigid criteria, but you have to understand very low risk. Anything out of this which is not fulfilling this, but still sort of low risk, is low risk. Now, intermediate again divided into favorable and unfavorable. Basically, they have 3 risk factors: T2B, T2 disease, Gleason grade 2 or 3, PSA 10 to 20. So I know these are some things which you have to learn. And if you have only one risk factor, and then Gleason grade has to be grade group 1 or 2. It cannot be 3. And all 6 core of 12 cores, all cores, positive cores, should have less than 50% cancer. Then it is intermediate favorable. So they're very, very, stringent categories as per the NCCN: favorable, intermediate, and low risk categories. Anything which is intermediate not falling into favorable is unfavorable. And then with, after 2016, NCCN introduced a very high risk from high risk segregated, because a lot of literature there. And they said, if you have one or more high risk features, that is T3, T4, Gleason grade 4 or 5, PSA more than 20. But if 2 of these factors are present, then it becomes a very high risk. So this is what we are in NCCN, and is doing a fairly okay job when we are managing our patients. EAU, similarly, low, intermediate, and high risk, grossly similar, minor changes there. So, if especially T2B or T2C category. But let us go more in detail. So then for our patient is T2C disease, because both lobes are, disease is palpable. Gleason score 8, PSA is 24.8. So, it falls essentially into the high risk category. Now, is it that simple? Just, you have numbers there and you plus and minus. So of course not. Otherwise, we'd not be having this topic at all. So there were so many papers, and this is the latest paper this year in February, when they are trying to, refine the risk stratification of high risk and local regional prostate cancer. And essentially what they say, they've pooled up the data of 10 RCTs, 3,600 patients undergoing radiation therapy, CN0 disease, Gleason 8, T3, T4, and PSA more than 20. And what they found, again, it is high risk versus very high risk, similar like picture, that if you have one risk factor, your survivals are better, but if you have 2 or more risk factors, your survival is bad. And similarly, that's very understandable. But what about, surgical patients? So this is on a paper we published in prostate cancer, prostate diseases, last year. So we try to do the National Cancer Database analysis. And this is, we really want to segregate every category of high risk, whether we can stratify or not. So we just took the patients, which were around, I think, there were around 60,000 patients in the study. Group H1 was only PSA alone. Group H2 was T3A disease, and Group H3 was Gleason grade 4, 5. So we actually segregated each factor. And since we have a big, large cohort from National Cancer Database from United States, we were able to segregate each of them, and we're trying to study what is happening, what is the role of different factor. Because I'm sure a lot of, urologists and radiation oncologists would have seen Gleason 3 plus 4 disease, but PSA is 70. And a lot of time PSA is 7, but Gleason 4 plus 4, which doesn't make sense a lot of times. So what we find that, if you have only PSA or if you have T3A disease, the survival 5-year was far better as compared to, Gleason score. So you cannot actually put all the 3 risk factors, that is PSA, clinical stage, and the Gleason in the same jargon. They have, different role. And that is what we found again, that, only those who are having bad Gleason, they also have a higher lymph node. They also have higher rate of adjuvant therapy, which is not true if you have only high PSA or if you have only clinical T3A disease. And I think this, we all have seen this in our practice, but this was, very difficult to document per se. What about Indian data? This is all West data. So we had the fortune, we analyzed our data of patients from All India Institute of Medical Sciences who underwent surgery, which is robotic prostatectomy. We had 53 patients with high-risk disease, and we had 26 patients who had only PSA as the sole factor for classifying them as high risk, while other patients had either Gleason or a higher clinical stage. And what we found again, that those who were having only PSA, they were actually doing better. They had a lower, high risk pathology, and they had a lower biochemical recurrence. And so the hypothesis which we gave is, in Indian patients, along with high risk disease, there might be a lot of chronic prostatitis, which could, falsely give you a higher value of PSA. Of course, it's all hypothetical, but we have to understand that PSA is not definitive. Apart from, going on to this jargon of three basic risk factors, that is PSA, Gleason, and the clinical stage, we are in the era of, precision medicine. We are in the era of molecular medicine. And so it is time, we have to have a lot of biomarkers which are going to stratify this. There's a whole array of papers. Every other paper has one biomarker added and say we are superior. But, I would just touch upon this paper, which, came in Annals of Medicine, which started studying the molecular classification of prostate cancer. We all know we have it in bladder cancer. We all know we have it in kidney cancer. Prostate is not very commonly used, but these are the 8 classifications they have made. Very difficult to learn for all of us. But grossly, what we say is, they use a genomic alteration, epigenetic modulations, and tumor microenvironment for classifying this. And this is sort of future. This is somewhere, as the precision medicine will come along, the risk stratification will improve. And so, I'll just summarize, saving some time here, that, prostate cancer is heterogeneous disease. Prostate cancer stratification is evolving. NCC and EAU, we all know, needs further substratifications with newer biomarkers. The major scope of substratification is in low or very low risk disease and high and very high risk disease. Importantly, low and very low, because we still have 30% failure rate of active surveillance, and high and very high, we still have, so much heterogeneity in that particular group. Some patients do so well, some patients do so badly. And there is the role of the molecular classification. And I think I'll thank you all for the opportunity, and we'll have to take the questions at the end or now if some question. But I'm sure I saved some couple of minutes there, Dr. Ashwin, because I think this is a very basic topic, and we all know it's a very heterogeneous disease. Thank you.
Yeah, thank you, Dr. Harshit. Excellent talk as always. Now, I am sure you have worked in India as well as in the United States, and I'm sure you have been using a lot of biomarker-based scores. For example, whether it's Prolaris or Decipher. Prolaris before going in for a definitive treatment, and Decipher probably after doing a radical prostatectomy to decide about adjuvant therapy. So what's your experience been with these kind of scoring? I mean, these biomarker score, systems like Prolaris and Decipher.
Honestly, Decipher is the most commonly scored we have used. I think in States it is very, very popular, and they were specifically using it, after the radical surgery for adjuvant therapy. That was the one, major indication. Active surveillance, actually, right now, States is, we were not using it very commonly, but most of the times, if you have a lower, there is a trend towards active surveillance globally. I think in the West, it is very strictly followed. And in low risk, very low risk, of course, but low risk and intermediate favorable risk, they would, eventually do active surveillance, and they are not using a lot of, these testing for, deciding whether surgery or no, but that should be done. In Indian setup, where I've been working, I've just used in one patient Decipher, but it is very, it is not a very commonly done thing right now. We are mainly on PSA and, clinical history and examination. So, in Indian setup, I'm not been able to use a lot of, molecular markers. Though one thing which I've been using lately is, in metastatic or locally advanced disease for genetic testing and, BRCA mutation. And that is, one upcoming thing, which is, olaparib. which is actually being used a lot. And there is Talapro trial now, and there is strong data that they're trying to put it in the first line with Abby or Enza with ADT, still not recommended in NCCN guidelines. But that is one thing which is gonna change, because this mutational analysis and genomic sequencing getting cheaper also day by day. And so maybe, that is one thing which we should use in stratification, localized as well in cancer.
Yeah,
What are your thoughts?
couldn't agree more with your take-home message that the real stratification can occur when you take these three D-amico criteria along with biomarkers. I think that would be the real sub-stratification that we will get. Thank you, Dr. Harshit. In the interest of time, we will have to move on to the last talk before the panel discussion. And this is going to be a very exciting talk, a very exciting topic on lutetium PSMA, the present and the future. It's a new kid on the block, but I'm sure it's gonna be, it's gonna be very effective in the days to come. So the speaker for the topic is Dr. Madhavi Chawla. She is the chairperson of nuclear medicine of Sir Gangaram Hospital. She is an extremely experienced nuclear medicine specialist with over 20 years of experience, having worked in various cities of India, so garnering a lot of experience. And she is a principal investigator, co-investigator for some leading cardiology-based nuclear medicine trials. And her special interest is in nuclear oncology as well as nuclear cardiology. Please take it away, ma'am.
Yeah, hi, good evening, everyone. I'll just share my own slides. Just give me a minute.
Absolutely.
Just 1 second. All right. So, can you see my slides?
Yes, ma'am, we can see you.
Yeah. Okay.
Yeah.
So, yeah. So, good evening, everyone. I would be speaking about lutetium therapy in castration-resistant prostate cancer, the present and the future. So, I'll be talking about the current and evolving landscape of lutetium PSMA therapy, the guidelines, other alpha and beta radionuclide therapies, combination therapies with some reference to the clinical trials. So, as we all know, castration resistant prostate cancer is a form of prostate cancer that. 1 second, something happened. My slides not sharing.
We can see
Yeah,
your.
you can. Okay. So, yeah, CRPC is a form of prostate cancer that progresses despite low testosterone levels achieved by androgen deprivation therapy. The treatments include androgen receptor pathway inhibitors, chemotherapy, and radionuclide therapy. So, radionuclide therapy is a form of internal radiation treatment that delivers radioactive particles directly to cancer cells using a targeting molecule. The various radionuclide therapies for prostate cancer are lutetium PSMA therapy, actinium PSMA therapy, and terbium PSMA therapy. Out of these, only lutetium PSMA therapy is FDA approved. The other ones are still in trials. So, what is prostate specific membrane antigen? Prostate specific membrane antigen is a transmembrane glycoprotein which is expressed on the surface of prostate epithelial cells. And these are greatly overexpressed up to 1,000 times in prostate cancer, particularly in advanced and metastatic prostate cancer and high tumor grade cancers. And PSMA targeting ligands are molecules which are designed to bind to these PSMA. These are then labeled with the beta emitting radionuclides for therapy and F18 and gallium for imaging. So these beta emitting radionuclide which are used for therapy delivers high dose of radiation to the prostate cancer cells with minimum damage to the surrounding normal tissue. So once these radio-labeled PSMA is injected, these ligands bind to the extracellular domain of PSMA. They are then internalized and concentrated within the cell where they give intracellular radiation, causing single-strand DNA breaks. Lutetium PSMA therapy got FDA approval in March 2022 in patients with PSMA positive metastatic CRPC who progressed under at least one novel androgen axis drug and at least one taxane regime. This was based on the results of VISION trial. Much recently, it also got FDA approval in March 2025 for earlier use before chemotherapy in PSMA positive metastatic CRPC patients based on the results of the PSMA-4 trial. Coming to these trials, if we see VISION trial here, heavily pretreated metastatic CRPC patients who were PSMA positive received lutetium PSMA therapy. The comparator arm was standard of care alone. And as we see, the progression-free survival was 8.7 months versus 3.4 months. Overall survival also was better, 15.3 months versus 11.3 months. Similarly, the therapy trial, which was metastatic CRPC post-docetaxel, high PSMA expression versus cabazitaxel chemotherapy, also showed high PSA response rate and imaging overall response rate. Both were higher than cabazitaxel chemotherapy. Then PSMA-4 trial, which was metastatic CRPC pre-taxane versus second-line ARPI. Again, progression-free survival was higher, 12 versus 5.6 months. And these treatments were generally very well tolerated. Now, the patient selection criteria. Lutetium PSMA therapy is only effective against tumor lesions with sufficient PSMA expression. First patient here, he has got no PSMA expression. However, FDG positivity is there. But this means that this patient is not going to respond to therapy. Now, FDG expression is generally, it happens when the tumor de-differentiates into small cell or a poorly differentiated variety. The second patient shows PSMA positivity. However, if you see there are some lesions in the liver which are FDG positive but PSMA negative, this patient again would not respond to therapy. The third patient shows both PSMA uptake and FDG uptake, would respond to therapy. And the last patient again shows PSMA uptake and FDG negativity. He again would respond to therapy. Now, this is functional assessment criteria. Different trials use different threshold of SUVs for inclusion. Like the VISION trial took lesion avidity higher than that of liver at least one metastatic site. The therapy trial took an SUV of 20 at a disease site. Lutetium PSMA trial was lesion SUV greater than 1.5 times the SUV of the liver. Now, contraindications to lutetium PSMA therapy. Life expectancy less than 3 months. ECOG score greater than 3. Acute urinary tract obstruction or hydronephrosis needs to be managed first so as to reduce the radiation exposure to the kidney. Other severe comorbidities like cardiovascular comorbidity, as these patients would require sufficient hydration both pre, during, and post therapy. Then progressive deterioration of organ function. For example, a GFR of less than 30 ml per minute, creatinine greater than 2 times upper limit of normal, liver enzymes greater than 5 times upper limit of normal, acute infections, and myelosuppression. Lutetium is administered IV over 10 minutes. A standard 200 millicurie activity based on the VISION trial is used. Up to 6 doses are given at 6 to 8 weeks of interval. We have to maintain good hydration, give prophylactic antiemetic therapy, and corticosteroids.
unable to move the slide, I guess. Roshni, could you be of some help?
Yes, sir.
I think she's unable to move her.
I can't move the slide anymore now.
Ma'am, you can just tap on the slide screen and it may help you.
I did that.
Okay. Could we share from our end, ma'am?
All right. I think it's just much easier if I can do it, but otherwise it's okay.
Okay.
No, much ahead of this. Okay, I can share it. I can see it now.
Yeah, could you
Yeah.
jump to the slide?
Yeah, so I'm there. Okay. So yeah, we finished this. So now, large field external beam radiotherapy and chemotherapy should be discontinued for at least 4 weeks prior to lutetium PSMA therapy. This is so as to avoid myelosuppression. Analgesics, ADTs, osteoprotection, and focused radiation therapy can be continued.
Excuse me,
Patients with,
ma'am. I'm sorry to interrupt you.
yeah,
I think Roshni has put up slide number 1. Actually, she's sharing from her end.
okay. So
Could
we
you
need,
to move to slide number? Could you please tell the slide number at which you were interrupted?
okay. Okay, one
Shall we
second.
stop sharing, ma'am?
Yeah.
Yeah, I think you can stop sharing. I think Dr. Madhavi is able to share her slides.
Yes.
So you can see my slides now?
No, ma'am.
Not yet.
Not yet. Let me try and do it again.
Yeah, now it's
Now, yeah. Okay.
yeah.
So I think there's some problem with this.
So, ma'am, you can tap on enable editing and then you can go for full screen. So,
Nothing's happening.
ma'am, you could see a pop-up
Can you
on the screen.
can you come to this slide, the one I'm sharing?
Yeah, sure, ma'am. I'll
Then
do
I can go ahead with what you're doing.
Apologies for the inconvenience. I think these things
No worries. Yeah, no worries at all. Yeah.
always
So,
can always interrupt us.
yeah. So, yeah, next slide. Okay, so patients with reduced kidney function, extensive previous chemotherapy, or history of prolonged hematological toxicity are more prone to develop higher grade myelotoxicity. Next, please. So this slide summarizes the entire procedure of lutetium PSMA therapy. We start with pre-therapy imaging, that is a PSMA PET to see adequacy of PSMA expression. This may be accompanied by an FDG PET scan, which is optional to see lesion heterogeneity. This is followed by laboratory tests, liver function tests, kidney, and CBC. Within 5 days of this, intravenous lutetium PSMA therapy is given. A post-therapy scan is done the next day so as to see localization, as well as some centers are now doing dosimetric calculations for tumor and normal organ absorbed dose. A follow-up PSMA PET scan is done after 2 cycles of lutetium PSMA therapy. Next slide, please. This is how the follow-up is done. First PSMA PET CT scans done, followed by lutetium PSMA therapy. First follow-up after 4 weeks. Second lutetium therapy, 8 weeks. The next scan is done after the second cycle, that is just before the third cycle. Next, please. So now prognostic factors associated with poor treatment outcome. Anytime that there is low uptake of radio-labeled PSMA ligands would result in poor treatment outcome. Similarly, heterogeneity of PSMA uptake, some lesions showing uptake, some not, poor response. Then visceral lesions show a poor response as compared to skeletal lesions. Lymph nodes show the best response. Next, please. This is a patient in whom the gallium PSMA scan showed lymph nodal and bone metastasis. He received 2 cycles of chemotherapy, 2 cycles of lutetium PSMA therapy, which showed significant response. The lymph nodes are not visualized, and the bone lesion in the iliac bone shows significantly decreased uptake. Next, please. Another patient, baseline PSMA scan after 2 cycles showing partial response, and after 4 cycles showing near complete response. Next, please. Side effects and toxicity. The side effects and toxicity are because of the physiological expression of these PSMA receptors at other sites, such as the salivary glands, the proximal renal tubules, the small bowel. So symptoms like fatigue, dry mouth, nausea, anemia, thrombocytopenia, leukopenia are seen. And the frequency is displayed here. This is on the basis of multiple trials. Most of the side effects are usually mild, grade 1, grade 2. Grade 3 side effects are generally seen only in 10 to 15% of patients. Next, please. Progression-free survival in key lutetium PSMA trials have ranged from 5.1 months in the therapy trial to 8.7 months in the vision trial. Next, please. This is because usually lutetium PSMA is given as a last resort therapy when the patient is either unable to afford or unable to tolerate therapy, or all other therapies have been exhausted. It would actually be worthwhile testing the efficacy of lutetium PSMA at an earlier stage of disease to improve the outcomes. Next, please. So these are the ongoing, the previous slide. Okay. So these are the ongoing trials of lutetium PSMA in early stage prostate cancer. The first 2 trials, the prelude and lutectomy trials, are investigating high risk localized prostate cancer patients before surgery, 2 cycles given before surgery. Then the PSMA addition and upfront PSMA trials are phase 3 and phase 2 trials for metastatic hormone sensitive prostate carcinoma. In the first one, the patient in PSMA addition trial, ARPI started within 45 days. And whereas in upfront PSMA, high volume metastatic hormone sensitive prostate carcinoma, where sequential lutetium PSMA and docetaxel chemotherapy would be given. Next, please. Now, in patients who have failed previous treatments, including lutetium PSMA, alpha-emitting radioisotope actinium is used for therapy. It has got higher energy, it is more potent, causes double-strand DNA breaks, and hence the chances of repair are very poor. So these are still in clinical trials. There's a trial called Action Trial, another one called Satisfaction Trial. These are for PSMA positive metastatic CRPC as well as hormone sensitive prostate carcinoma. This shows significant tumor reduction and favorable response rates. Next, please. Another isotope is terbium. Terbium PSMA therapy is also in clinical trial phase. Terbium emits beta particles as well as Auger electrons. So it's a combined effect. Beta particles give radiation or cause single strand breaks. Auger electrons give double strand breaks. So the response is higher. It also has gamma radiation for imaging. Next, please. Again, next. So there are other things which have been tried, like dose fractionation and dose escalation studies. In dose fractionation, the same dose is divided into 2, like for example, 40 to 90. Instead of giving 200 at one time, 40 to 90 is given on day 1 and then 2 weeks apart. Another 40 to 90 dose is given. This principle is taken from radiotherapy, that we give enough time for the cells to recover. Similarly, dose escalation trial, a first lower dose is given, and then day 15, a higher dose is given. This is in order to achieve a higher effect and higher dose. Next, please. Now, there are certain combination trials which are being tried with the immune checkpoint inhibitors, PARP inhibitors, cabazitaxel, enzalutamide. These are all phase 1, phase 2 trials to assess the synergistic effect of these drugs with lutetium PSMA. Next, please. So to conclude, this is what it is. Lutetium PSMA, currently FDA approved for metastatic CRPC. It improves survival and quality of life with low side effects. And in the future, we are looking at alpha emitters and terbium, which are in development, and radionuclide therapy moving earlier in disease course so as to expect better results, and trials exploring combinations and personalized strategies. Thank you.
Thank you. Thank you, Dr. Madhavi. I think this has served as an eye-opener to most of us, because I think most of us are not yet, exposed to lutetium therapy in the way that it has to be utilized. I think this is an exciting era where we are actually having more and more options for metastatic castrate-resistant prostate cancer. And now with the new evidence coming in, I think, could you just please throw some light on the cost of lutetium therapy so that we have a ballpark figure how much it entails?
So lutetium therapy, we can source lutetium from two places. One is BRIT, which is Mumbai, BARC Mumbai, and the other one we get from abroad. So the charges are quite different. Lutetium PSMA therapy, if we get the isotope from India, it would come to around 1.25, but if we get it from abroad, it comes to about 3.5. It's majorly the cost of the isotope. A lot of times we have to admit patients for therapy, even though it's allowed to be done in OPD basis, but for insurance purposes, a lot of time we have to admit that, so that adds to the cost. Otherwise, it's basically the cost of the isotope. That's it.
What about the toxicity of lutetium PSMA? What kind of toxicity do you see in patients?
See, commonest is salivary gland pain uptake, because there's a huge concentration of lutetium PSMA in the salivary glands. Then kidney toxicities are there, so that is why below 30 GFR or high creatinine value, we don't do lutetium PSMA therapy, or the dose has to be reduced. Then similarly, fatigue is pretty common. In patients with extensive bone metastasis, myelotoxicity, anemia, neutropenia, thrombocytopenia, all can be seen. But these are very rare, and all the number of patients we have seen so far, there are very few patients who needed a blood transfusion or anything else to manage these toxicities. So the dose can be reduced accordingly. And that's it. So these are the main toxicities: the salivary gland, the kidney, and hemopoietic.
Finally, one last question I would like to
Yeah.
ask you. When you are considering for castrate-resistant prostate cancer, do you
Yeah.
ensure that during the castrate-sensitive phase, they have
Mm-hmm.
received at least one secondary hormonal agent like
Mm-hmm.
abiraterone or enzalutamide,
Yeah.
uh, or one taxane before
Mm-hmm.
you consider giving this? Or because many times patient can be on abiraterone or enzalutamide and become castrate resistant, that is apart from the ADT. Uh,
Mm-hmm.
do you think that this is the right indication that you can give it even after abiraterone and enzalutamide, or do you ensure that, I mean, do you give the option that they can go on a taxane and then come on to this therapy, lutetium therapy?
They can go on. The initial trials used to say that they can go on taxane and then come to this. But now the latest trials are allowing us, like the PSMA-4 trial, the PSMA addition trial. They are all allowing us to do it at an earlier stage.
Okay. So again, so we didn't touch upon this topic of radium-223. Okay, that is also
Yeah.
given in NCCN guidelines as one of the options. So what is
Yeah.
your experience? Do you have any
So
experience?
no, we have not done it. I would not have much experience on it.
So is it not available in India, radium 223?
Uh, it is available at places, but I'm not too aware of that.
Okay. And actinium, when would
Yeah.
you reserve actinium for beyond lutetium?
Patients who've stopped responding to lutetium PSMA therapy.
Okay. Okay. I think this thing is more so for like liver metastasis.
Actinium, yes. Actinium, liver metastasis respond to actinium, not as much to lutetium.
Lutetium. Thank you, ma'am. There would be
Yeah.
some points in our panel discussion because
All
I'm
right.
including nuclear medicine questions as well. So I'd be
Yeah,
happy if you could just stay around for the panel
yeah,
discussion.
I'm around, but Dr. Ethel's there already to answer all your questions. Yeah.
Thank you. Okay, so that brings us to the final session of the evening, which is the panel discussion. I would like to share my screen. So the panel discussion, so I would be moderating the panel discussion. I'm Dr. Ashwin Malia. I'm a uro-oncologist from Sir Gangaram Hospital, New Delhi. So in my elite panel today, I have Dr. Ethel, who is a nuclear medicine specialist from Dr. Gangaram, Sir Gangaram Hospital. Dr. Veronica Arora from Clinical Genetics, Sir Gangaram Hospital. Dr. Navdeep Singh is a medical oncologist who is joining in from Ludhiana. Dr. Arpita Gupta, who is a radiation oncologist from Sir Gangaram Hospital. And Dr. Givi Gaurav, who is a uro-oncologist from Precision Hospital, that is based in Lucknow. So I would request the panelists to give brief answers. We can obviously, we can extend if needed, but let's make it to the point in the interest of time. And because I want to cover at least 2 to 3 cases, let's see how it goes. I'll be sharing my screen now. So is my screen visible?
Yes, I think it's visible. You can make it full screen as well.
One second. Yeah, I think now it's better.
Yes.
Yeah, one second. Yeah, okay. So again, thanks once again to the IAIO for giving this opportunity, Dr. Aditya Sareen, who included me for this webinar. So I've introduced my panelists. So Dr. Aditya Sareen could join in as well for the panel discussion, and Dr. Shikha Haldar also if she's around. So my first case is a 77-year-old male with the PSA of 34. I would request the panelists to please switch on their videos so that we can have them on board. Yeah, thank you. So the first that I can see some faces. That makes it easier for me. Okay, so this is a 77-year-old male, a very healthy guy. Otherwise, with the PSA of 34, it was incidentally detected when he was examined, when he was investigated for some obstructive LUTS. So on digital rectal examination, he has a hard nodule in the left lobe of the prostate. ECOG performance score is perfect. He's very active. Uh, Only history he gives, he has a single stent when he was diagnosed to have a coronary artery disease and he underwent a PTCA in 2019. He's a non-diabetic, non-hypertensive, very active, volunteers in the local library, very active lifestyle. Previous history of a road traffic accident, had a shoulder injury, which because of which he had an injury to the scapula. So on MRI, there was a Peyer's 5 lesion, around 2.5 centimeters in the left peripheral zone, in the apex and midgland. Seminal vesicles were free. The left neurovascular bundle was involved. And a trust biopsy done in another hospital, when he presented to me with the biopsy report of a Gleason 3+3, 6 out of 12 cores were positive, all on the left side. A PET scan revealed organ-confined disease. Okay, and organ confined disease, left prostatic lesion, SUV max of 6.6, no avid lymph nodes. But here comes the twist in the tail. He had a small scapular lesion, which was around 2 into 1 centimeter with an SUV max of 4.4, and there were no visceral mets. Okay, so this was the lesion that was picked up on the prostate and on the scapula. So, questions for the panel. So, I'd like Dr. Givi Gaurav to come in. Are you happy with the biopsy report when you have a patient who presents to you from another hospital? Do you take the biopsy report on face value, or do you get it reviewed by your own pathologist?
Good evening, Dr. Ashwin. Am I audible?
Yeah, you're audible.
Yeah, hi. Thank you so much for this opportunity, first up. I would probably get the biopsy report reviewed because that's a standard practice at my place. That if we have a slide and block which is available, then we get it reviewed by it.
Okay, excellent. I think that is something that most of us do. When an outside report comes, we get it checked. And again, it was Gleason 3+3. Even in our own hospital, so there was no change in the Gleason score. So I would like Arpita to come in. Would you investigate the scapular lesion further? Do you need to?
Yes, actually, the scapular lesion is a bit odd because it would change the management on depending on whether it's positive or negative. So if the PET-CT report says that it's query metastatic, then in that case, I would go ahead with a CT-carotid biopsy. And then
CT-carotid biopsy. So point is very well taken, because the biopsy of the prostate is not matching up with, and the PSA, one PSA value of 34. Okay, so now with that kind of, there comes the ambiguity. So you have a PSA of 34, but a Gleason score of 3+3. So knowing the limitations of both, because we've seen Dr. Harshit's talk where he mentioned that Indians were having higher PSA values due to concomitant chronic prostatitis, and the biopsy report again was not matching up to the Gleason score. So a CT guided biopsy was not done at this stage. So I'll come to that later, because at that point of time the family said that we do not want to go in for a biopsy of the scapular lesion. So Dr. Givi and Dr. Arpita, at this stage, how would you counsel the patient?
So if I can come in here, Dr. Ashwin, I think one of the things which we need to clarify over here is the scapular lesions, as you said, does not correlate with the clinical or the PS or the Gleason grade finding. And as Dr. Harshit told us that PSA in Indian patients and the Gleason scoring don't have a very definite correlation. Some of the PSA, we are also known as the PSA non-secretors, wherein we have very low PSA values and yet we have a very distant metastasis at times. In this particular case, there is a IPSS of 19 if we look at the initial side. So that could also have a contributory factor for the PSA going up. And given that the MRI as well as the biopsy, which has been reviewed by our own panel, gives a 3+3 grade, I would still suggest that to counsel the patient, I will tell them that yes, there is a possibility that you may be harboring a lesion in your scapula. However, a SUV max of 4.4 is not really very reliable, given that he's already had a history of some injury to that region. So I would still say that we can treat this as a localized CA prostate and proceed with that kind of treatment. We will keep the scapular lesion under surveillance, and thereafter, if the scapular lesion or there is a biochemical recurrence, then we investigate that further.
Excellent points you made, Dr. Givi, and that's exactly what I did. Dr. Arpita, would you differ? You already wanted a CT-guided biopsy, but patient has refused. So would you, suppose you were taking up this patient for radiation, would you also give a disclaimer of this sort, like that we'll keep this under surveillance and see how to go about it?
needs to be kept in surveillance.
Excellent. Dr. Ethel, do you have to say anything about the SUV max of 4.4? At what point of time do we start suspecting a metastatic bony lesion?
Well, see, SUV max
There is no cutoff. Let me just say that upfront. If there is mild uptake, the correlation between the PSMA uptake in the prostate and the metastatic site, most of the time it corroborates. But sometimes there may be, differences in the uptake in the prostate primary lesion as well as the metastatic side. And some of the lesions may not be that PSMA avid as well. So there's no cutoff for the SUV max.
Yeah, Dr. Santosh wants to make a quick point. I think he's raised his hand. If you can just make a quick point.
Yeah. Ashwin, just to add, in the biopsy, it would be good to look at the cores taken and the maximum core length. If you have mentioned it, I've missed it. The reason is because I'm looking at possible undersampling. If the MRI is picking up good contrast pickup, then there is definitely an undersampling in the biopsy, and this patient may require another biopsy to prove that it's not 3+3 but 3+4. I'm just trying to be a devil's advocate here. So
yeah, absolutely valid point. The biopsy, the core lengths involvement in the 6 cores was varying between 10% to 40%. Okay, and sorry, I did not put up that information, but very valid point. Even in our biopsy review, which I went and saw personally, they were pretty sure that it was 3+3, but undersampling is definitely something that came to my mind. Point is well taken. So, Dr. Gibby, do you offer neoadjuvant treatment in your radical prostatectomy patient? Like, although it's not in the guidelines, but if there's a patient, not exactly like this, but would you put them on neoadjuvant treatment?
To be very honest, we really don't have too much of an experience with that. We have basically 3 patients whom we have tried. Actually, we have only put them on LHRH antagonists because there was an earlier patient who was on an agonist from somewhere else, and we did we don't have a robot, so we did a lap radical prostatectomy on him. The normal planes were very stuck, and we really didn't have a very good experience with agonists. We have a couple of patients on LHRH antagonists though, and we are waiting for their follow-up. And if the lesion size improves and they become amenable for treatment, I think that will be the time when I can give you this answer. I think somebody else should be.
Let's, for the sake of argument, let's assume that this is a metastatic lesion, and this is an oligometastatic lesion oligometastatic patient that we are dealing with. Would your decision for neoadjuvant hormone be there?
As of right now, because it's really not there in the guidelines, I don't know how I would be able to tell that to the patient or the relatives. And given the size of the lesion in this particular case, and maybe a similar case, which is oligometastatic, maybe we can do an adjuvant treatment later on and save him. The whole idea in this would be saving him the side effects of an ADT. So if we are able to treat the local disease and maybe take care of the oligometastatic disease with RT, he does better without an ADT. So that would be my thinking in this.
Okay. What about you, Dr. Arpita? Suppose this were to be an oligometastatic, and we know that radiation to the primary in low volume metastasis in the Stampede trial has shown overall survival benefit. How would you deal with such a situation?
So if this was considered to be oligometastatic, I would start off with ADT and then consider the patient for prostate RT as well as RT to the scapular lesion in an effort to save the androgen receptor antagonists for later.
Okay, you would start androgen receptor pathway inhibitors for later.
This is otherwise very low volume. The primary disease is also small with Gleason's 3+3 and just one scapular lesion. So it's coming up now, but
can I just ask something, Dr.
Yeah.
And since we are at that, suppose we give him 2 injections of ADT and we do a PSMA and there's no disease seen anywhere.
So that's exactly why neoadjuvant hormone, the question was put forth. So there was a discussion in the department where I work whether we should be giving 2 injections and look at the lesion as to how this would behave after some time. But we did not do that. So I'll just want you to be patient. We'll go on with the case. So Dr. Arpita has predicted some of the questions and she has answered them already, that RT2 primary is definitely a possibility since this is a oligometastatic disease and RT2 primary has shown overall survival benefit. And metastasis directed therapy or wait and watch is a thing that both panelists wanted to consider. So I think we'll just move on to the genetic testing question. Dr. Veronica, could we have you?
Yes, I'm here. Hi.
So this is a case where we have a Gleason 3+3, which is supposedly low grade, but we have a suspicious lesion in the scapula, which could be a metastatic lesion, and the PSA was 34. So, do you recommend genetic testing? And what if, I mean, in this patient, for example, this patient had already undergone a genetic testing for HRR gene mutation when he came to me. So he had a variant of unknown significance. So what is it? And could you please explain?
So that's a very long question, right? And the indications of genetic testing includes both for a locally advanced and metastatic tumor when we have a high grade and a family history that is present, and especially in more than one first degree relatives of breast as well as prostate cancer. So in this case, in PIRADS 5, which indicates a high suspicion of a clinically significant disease, genetic testing is definitely crucial for the risk stratification and for planning treatment. We know that germline testing for HRR genes, which include BRCA1, 2, ATM, CHEK2, PAL-B2, these genes plus the MMR genes is important to understand that if we can do any treatment modifications like use of PARP inhibitors for the same. So now we come on to what if we detect a variant of uncertain significance. So now it depends on which testing is this variant detected. If the variant of uncertain significance is detected in the germline sample, that is in the blood of the patient, we can make sense of it by testing multiple other family members, especially the ones who have crossed that age. And if it's a BRCA variant, we can test both males and females. And by that stratification risk testing, we can understand that if that variant is known in that family to cause a disease or not. Then there are various databases like Franklin and Decipher, etc., which we have to study that variant characteristics and maybe to reclassify that variant. So that is about the germline variant. Somatic variants classification is very different, and we have certain specific cancer specific databases to study the variants of uncertain significance in the somatic setting. We study the protein level changes and the amino acid level changes to ascertain if that variant would later be a pathogenic variant or not. So the best genetic database that we have and we believe is a ClinGen curation. So if any variant is curated on ClinGen, then we can confidently say that the variant is pathogenic. And if it does not, we cannot take any treatment related decisions based on the variant if it is not reclassified or originally classified as a pathogenic variant.
So I just wanted to bring forth this point that genetic testing is definitely indicated when there is a locally advanced or a high risk prostate cancer or a metastatic prostate cancer, and the results of which, of course, are best interpreted by a clinical genetics expert. And there would be a certain amount of counseling required pre-test and post-test. So that is the point I wanted to drive home. So we are waiting for the results of this trial, which is the SWOG S1802, which is a phase 3 randomized control trial of standard systemic therapy versus standard systemic therapy plus definitive treatment. So this is an RCT, so the results of which are still awaited and the patients are still being accrued. Now, there are some trials like the HORAD trial, which studied ADT alone versus ADT plus EBRT to the prostate, which did not give significant OS benefit in the full cohort, but there was a significant overall survival benefit when there was a low metastatic burden, which was not statistically significant, but was showing some trend towards it. And also, interestingly, which surprised me. There were fewer prostate-related events in the RT arm. So the Stampede trial showed us that there is definitive overall survival benefit in low volume disease. So just to kind of complete, so this case was taken up as a oligometastatic disease, and this patient underwent radical prostatectomy, and the final histopathology again came on to be 3+3. So we were right with the initial biopsy. So the margins were negative, the lymph nodes were negative. So surprisingly, after this, because we had considered that we would keep him on close surveillance, but with this kind of report, we went and biopsied that scapular lesion. And interestingly, it came out to be non-malignant. So we have still kept him under surveillance now. But having said that, the clue was in the previous injury that there was some lesion there, which turned out to be non-metastatic. But we are definitely going to keep him on surveillance.
Dr. Ashwin, can I come in?
Yeah.
So, your question of genetic analysis, I think soon you will have a completely new, different way of looking at things. Even now, patients with, castration-sensitive tumors are going to land up with analysis in the terms of HRR, and at least not HRR, then at least minimum, bare minimum BRCA gene. So recently in ASCO 2025, we had the data subset published of the Amplitude trial, where subgroup analysis was done, where PARP inhibitor niraparib along with the ADT and the hormonal treatment was given versus the placebo and ADT and AR antagonist, which showed 37% reduction in the subgroup where the tumors are HRR mutated in the castration sensitive disease, and patients such as this, I think thought where Dr. Gibi also said, if you would have gone for a 2 neoadjuvant doses of, your hormonal treatment and the disease would have vanished, I think you would have still gone for the surgery and radical prostatectomy, but then you would have gotten the answer that the lesion which we biopsied now is really responding to the hormonal agent. So the neoadjuvant role of LHRH antagonist, even in the curative setting or even in the oligometa setting, it plays the same role. And in fact, I think if we give 2 doses of LHRH antagonist, I think it shrinks the prostate volume for you guys to as well, go in a minimally invasive way and to have a least amount of morbidity perioperative or post-operative.
So the only thing that has been proved so far with neoadjuvant hormone is negative margins. No benefit in BCR, no benefit in overall survival. But probably we will have those studies coming in soon. Point well taken, Dr. Aditya.
OS is going to be very difficult in prostate cancers because generally the drugs that we have, they keep on making patients longer and longer in both the arms because they keep on switching the arms as well. No? There is a crossover effect. So maybe we will never get the answer in terms of OS. So we will have to restrict either in terms of scatter-rated events or PFS or distant-free metastasis, something like that.
So I think metastasis-free survival, progression-free survival are good surrogate markers. And another point I wanted to make, we already discussed that. I think probably you missed that point, where we are already doing genetic testing for high-risk high-risk localized and high-risk locally advanced as well as metastatic castrate-sensitive prostate cancer. So thank you. With that, we finished first case. So moving on to the second case, this is a 68-year-old male.
I think let's discuss 2 cases only. Everybody is like, on toes now.
Yeah,
even your wife was looking at you. Kya kar rahe ho?
This is the first time I'm with Dr. Ashwin on a Saturday like this.
Yeah.
हमें तो बुलाते भी नहीं है, sir.
So without further delay, let's get on to the case. So 68-year-old male who presented with urinary retention, he was catheterized and the PSA done sometime after the retention, because retention can falsely raise, but sometime after the retention, the PSA was 80. So when he came to us, he had on examination, he had a hard nodular prostate. A TRUS biopsy was done, which showed Gleason 4+5, all right-sided cores were positive. His ECOG performance score is 1, asthmatic, diabetic, hypertension, hypothyroid, with a hemoglobin of 10, creatinine of 1.6. Okay, so this was his PSMA PET scan, which showed PSMA avid nodal metastasis as well as bone metastasis in around 4 to 5 sites. Okay, which included the axial skeleton as well as the iliac bone. So now we have a patient who is metastatic, castrate sensitive, you can say, high risk, high volume metastatic disease. So how would you counsel Dr. Aditya or Dr. Any of the medical oncology, Dr. Navdeep, to come in?
I think Navdeep is here. Navdeep?
I think he is busy somewhere. So Dr. Aditya, you can take up.
He must be busy. Okay. So patients who are satisfying the criteria of having in high risk and high volume, I think there is no question left for the triplet now. And considering the availability of the drugs, I think for me, the go-to-go answer is going to be a triplet over here.
Okay, so we have a patient who is not very senior. He's 68, but he's ECOG performance score 1, and with a creatinine of 1.6. What are the points you decide that this patient is going to tolerate triplet therapy? So triplet therapy. Could you please explain what is triplet therapy to the audience, if you can? What all include
It's
that?
like giving everything up front, and now we are moving to the quadruplet therapy as well. I think I will skip that discussion. For a triplet to be a triplet, it has to have a chemo backbone, an AR antagonist, and a ADT. So that becomes your triplet. And the evidence is from the ARASENS and the PEACE-1 trial, where in the PEACE-1, the ABIRA along with the LHRH antagonist, or I think even the agonist, were also incorporated along with the abiratron, along with the docetaxel chemotherapy. All the three things, they landed up with the higher significance of the PFS. And the same was demonstrated in terms of ARASENS trials, where darolutamide along with the docetaxel along with the ADT was given. So it was found that when the subgroup analysis was done, the majority of the benefit was driven by the tumors who were having high risk or high volume disease.
Okay. So, Dr. Gibi, I would want you to come in here. So here is a patient who has a retention. So your choice of agonist versus antagonist versus orchiectomy, and plus or minus channel TURP, how would you deal with this situation?
I think it would depend a lot on how the patient is and what are his wishes, etc. I didn't get the prostate size or the median lobe, etc. I believe that would be a high prostate size and a median lobe and an
Yeah, he's in
obstructing gland.
retention. He is catheterized. He's catheterized.
Exactly. So I think it's best that in a normal setting we would offer him a channel TURP and an orchiectomy, which will get him rid of the catheter, and institute an ADT, which he is probably going to need lifelong, and that will somewhere also bring down the cost, which may be associated, since I totally agree with Dr. Adit that he's a candidate for triplet therapy. So there is a cost angle involved if he's going to be on an antagonist or an agonist along with
this conference right now is purely based on academics, and when we are discussing academics, so I think let us keep the cost aside, because students get confused and they give the same answers in the viva.
I would
and,
still, since he's on retention, and in this cases, in our practice, we have seen that there is no benefit of a trial void and trying to go with a alpha blocker. So in my case, I would counsel him for a channel TURP and an orchiectomy to begin with, and then once the wounds etc. are taken care of, then he goes on to the other aspects of the triplet therapy.
What's the plummeting level of testosterone once orchidectomy is done and versus, let's say, LHRH antagonist? Is it different or is it same?
See, the antagonist will have a flare phenomena initially. The antagonist, you meant. Sorry. The antagonist will obviously have a castration level of 0.2, which pretty much is what we get with orchiectomy. So there's not a major choice between these two. If the patient is, I think this particular patient is quite fit for surgery, given that he has a few anesthesia risks. But apart from that, if he is willing for surgery, I would offer him channel TURP and orchiectomy, and if not, if we explain the whole, if he can continue on an antagonist with a catheter for a coming few weeks or months, then after the antagonist has taken effect, maybe we can give him a trial void. If that trial void is successful, then we keep him on medical management. If not, then he has to do something for his obstructing gland also.
One point I would like to make here is so orchidectomy is an irreversible thing. So LHRH antagonist or agonist, whichever. So in this case, we would prefer to give an LHRH antagonist whenever there is impending obstruction, existing obstruction, whether it's to the bladder outflow or to the kidneys or impending spinal cord compression. We would like to give LHRH antagonist or do an orchiectomy, which has instant effect. And LHRH agonist is not preferred because it would have a flare phenomenon which could worsen these symptoms. But having said that, I think it's the academic discussions. I agree this is an academic discussion, but the economics of cancer care has to come into play when we are training oncologists to take care of Indian patients. So
I think that depends upon the institute. But if anybody were to answer me orchidectomy in the era of LHRH antagonist, where you have tablets and in the injection form, it just doesn't make any relevance. In so many years of I being practicing now, I have referred only one patient for orchidectomy, and that too because the patient was going to land up with a severe spinal cord compression. With these kind of LHRH antagonists now, I really don't think that there is any need of getting the orchiectomy done. So, Dr. Ashwin, the counter question to you is, which is the scenario where you will say, boss, यहाँ तो antagonist और agonist तो देना नहीं है, यहाँ तो orchiectomy ही करनी है. Which is the category 1 recommendation?
Yes, the category 1, I can't say it's a category 1 recommendation, but a very practical point is when the patient is in retention and even after giving your antagonist, he doesn't void. Okay,
so how many are those?
A lot.
Can I come in here, Dr. Ashwin? I don't know if Alok is still on the panel, but there is a patient of Alok's who is on antagonist, who has been on antagonist for some time now, and he has been failing catheter-free trials for the last, I think, umpteen times, 3 or 4 times almost.
I think, let's move on to the next question.
Yeah, I guess so.
Point is well taken. I think it's a practice-based thing. So medical oncologists probably would prefer to keep them on LHRH antagonists. So choice of androgen receptor pathway inhibitor. So whether you're giving abiraterone or enzalutamide or apalutamide or anything else, how would you decide?
So for a triplet, I think you have the approval of only 2 drugs, which is abiraterone and darolutamide. And for a doublet, I think you can choose any of them. Then you have to decide the side effect profile and the logistics and how compliant your patient is, your comorbidities like diabetes, hypertension, cardiac issue. So it all depends upon the patient profile then. But if I have to give triplet, only 2 are there, abiraterone and darolutamide.
Okay. So any other investigations apart from all this? Do you need a DEXA scan to decide about certain medications to be given?
Well, I think patients who are going to get abiraterone, then you need to give Visalon. And if you have a patient who is going to take Visalon for longer term, it can increases the risk of osteoporosis in patients who are underlying having a bone disease, which can ultimately lead to a higher skeletal-related events. There, I would like to do a DEXA scan and start the patient on a Zoldria or denosumab 6 monthly, not monthly. There is absolutely no role of giving Zoldria and denosumab monthly basis. And I see, prescription left, right, and center from Pan India, even in the castration-sensitive prostate cancer patients, everybody is prescribing it, and we don't have any data to support that.
So the guidelines say that in castration-sensitive prostate cancer, if the skeletal related events risk, there are certain calculators which you can use.
Yeah.
When that is elevated, only then you are giving denosumab. But in
and that
all
too 6 monthly, not in a monthly fashion, in a 6 monthly fashion.
Okay. So in castrate-resistant prostate cancer, I think it has entered the guidelines that it has to be given in all.
No, absolutely not. There is no data, sir. There is no data. In second line, there is data to support that these drugs decreases the incidence of SREs. But in front line, there is you quote me any one trial where front line denosumab, along with the ongoing treatment, has shown an improvement in the SREs. You will not find even a single one.
Okay, I think I don't have an orthopedic person here. I think they would be the best people to comment about the risk of SREs in people who are probably on 6 monthly denosumab versus probably 4 doses of monthly denosumab, the way many people are managing. Okay, and genetic testing. So, Dr. Veronica, I think how would you have already explained to us that genetic testing was definitely on in the previous case as well. But in this case, what are the genetic panels that you would order in such a case?
So this is a high risk case. So all the guidelines, NCCN, AUA, EUA, all offer the germline genetic testing here, and that includes your HHR as well as the other MMR findings. And there are some genes except these like CDK1 and PIK3CA that can be included as well. So these genes do help us predict the risk of metastasis and prognostication as well as your treatment based decision. So we do germline testing for sure, and the somatic testing can help in your treatment-based decisions in this case.
I think, we are referring almost all cases of, breast, ovarian, pancreatic, or, prostate cancer to Dr. Veronica, so that at least we can have a germline value of these mutations. And sooner we will be asking her to do the HRR testing in all the castration-sensitive prostate cancer, and that too upfront. Earlier, the role was to do it in the second line to know which kind of path to be at, like PROPEL study. And but now the things are changing way fast than I anticipated.
Okay, and Dr.
It's a strong indication for genetic testing as of now. Yeah.
Yeah, okay, point is taken. So, follow up, Dr. Ethel. PSMA PET scans. Generally, in castrate sensitive prostate cancer, when we have started therapy, how often would you recommend that we do PSMA PET scans to look for changes?
After 6 months, after 6 months of starting the treatment, not earlier than that, unless the patient has new symptoms.
Mhm. Suppose this were to be a doublet therapy to begin with. How would you sequence, Dr. Gibi and Dr. Aditya? How would you sequence the therapies?
I would probably refer it to a medical oncologist for the proper sequencing. But since we manage most of our patients here, what we do is given that either we go with a antagonist. If we have gone with an antagonist, we'll probably start off with an ARPI at the same time, give him a trial void, see how he's voiding. If he's doing well, then maybe once the UTI etc. is settled, once his renal functions are all right, and if he is okay to tolerate docetaxel, then we start him on a docetaxel. If we have done a channel TURP orchiectomy, we wait for the wound to heal, we wait for the voiding, etc., to become normal. And at the same time, we can obviously start him on ARPIs. And then once the healing, etc., is complete, he is doing better, then we start him on the docetaxel.
So, Dr. Aditya, what are your considerations before starting docetaxel? Suppose this patient has progressed. Okay, what are your considerations whether a patient would, tolerate chemotherapy?
So it all depends upon the confidence of your medical oncologist. So we have patients who have been successfully treated with a minuscule dose of docetaxel in the worst of the worst scenario. So to be honest, it boils down on the patient's performance status, his comorbidities, and the willingness of a urologist to send the patient for chemotherapy department. So I have given chemotherapy in a patient who is 84-year-old as well, and he has been doing it remarkably well, outsing the outside reference which showed that you do the chemo, he's not going to make it. So with that kind of intent, once patient comes to us in OPD, it becomes a challenging task for us to get them convinced. So I think the change should start at home. If we are using a doublet in front line, the benefit is going to be 40 to 50 months, not more than that. But if we use singlet, only a single ADT, it's hardly going to be an year or 2 year. But if we use triplet, it is more than 65 months. And that is why I tell everybody that if you have a fit patient with a high risk, high volume, please think about triplet. You are helping the case in terms of data we have in both the trials. Now, considering that if the patient has gone for the doublet and now is being referred for the sequence, obviously the next AR antagonist or AR inhibitors are not going to be performing that well. So what I generally do, I ask them to hold that AR antagonist. We continue with the LHRH agonist or antagonist, whichever was there in the previous line, and you just add a chemodocetaxel so that you give a little bit of a break from the AR inhibition.
Okay, now coming to suppose, Dr. Ethel, this were to be at castrate resistant when there has been progression and patient has, this problem that there is obstruction, he still has bladder outlet obstruction. Would you still consider him for lutetium after resolution of the obstruction, like after a TURP or something? Would this kind of patient who has progressed with high risk, high volume, would you consider for a lutetium with this kind of creatinine of 1.6?
Yeah, actually, creatine of 1.6, what we do is that we will subject the patient to DTPA scan and also calculate the GFR, which will have evidence, scan-based evidence of the kidney function. And if the GFR is more than 30, then we can go ahead, and now we have fractionated dose also. We can give fractionated dose as well. So why not? The patient is a candidate for lutetium therapy.
Okay, so Dr. Gibi, I want to ask you, what is your, if a patient turns out to be very stable, suppose he has not progressed, he is very stable, his PSAs are all like undetectable or very low, would you consider giving him a break from the ARP inhibitors as well as ADT, which is basically in the realm of intermittent ADT?
I don't know so much about the ADT because I've seen that one of the game-changing things for me has been relugolix in the practice because it's a tablet antagonist which people have been taking without a problem. So from antagonist to agonist, I really don't know. I don't think there'll be a consideration for that. However, what we are doing is we are giving for ARPIs, we are giving 250 once it's stable and the PSA is in undetectable range. We are using the 250 mg dosage after a fat-free meal once a day. And we have seen that to work pretty well in those patients who are completely, the PSA is less than 0.04, etc. They seem to be doing well and the PSA levels have been maintained. So yes, ARPI dose reduction for abiraterone, yes, it helps them go off the Visolone a little bit, and the dose reduction helps them. I know it's not supposed to be academic. I mean, it's supposed to be academic, but yes, it helps the cost reduction, helps the side effect profile as well.
So, Dr. Aditya, what has your experience been with PARP inhibitors?
To be honest, not a really great fan of PARP inhibitors in the second line. But now, after looking at the amplitude trial, I think I will have to change my practice from tomorrow. And at least in the castration sensitive, I am going to get it done upfront. So let's see how the niraparib availability in India it's going to change in the next few months.
Okay, so I think I think with that we can stop the discussion because I can go on and on, but I just wanted to kind of just send you with this slide, which is basically systemic therapy for metastatic castrate-resistant prostate cancer. So there are very good guidelines available from NCCN as to there are multiple therapies available. The category of the evidence available is mentioned. So when to use lutetium, when not to use, and when we can use a combination of PARP inhibitors with ARPIs. So all these things I think are very helpful in practice. I think overall, I think the point I wanted to make was this is not medical oncology versus surgical versus radiation. Ultimately, it has to be a team approach along with the help of genetics and nuclear medicine and pathology. And I hope the collaboration continues, just like Jay and Viru would be continuing. I hope Aditya and I can, actually be riding on a bike happily and treat patients. Okay. And with that, I come to the end of my panel discussion. I'd be happy to take, I think there are some questions in the chat. Yeah, I think more or less I think we're not going for the third case. So I think more or less we are done with the questions. So I think we have taken, I think with that, I'd like to thank IAIO again for this amazing opportunity. So we had about 130 participants today at the peak of the program. And that's a very good number considering it's a Saturday evening. Thank you very much. Aditya, you want to say something? I would thank all the faculty who were there, and I would like to, thank IAIO and Aditya for giving me this opportunity. Thank you all faculty and other participants as well.
Yeah, thank you, Dr. Ashwin. And obviously, when we were conceiving this idea of having, a dual malignancy kind of a scenario in the completely academic forum, and mine too, that too without any, sponsorship, we were both looking at each other faces, who will come, who will not come. But then again, I think we did a pretty good job, and you can just see we had like 430 plus registrations with approximately 200 PG students were there. And we had faculty, 35 plus faculty with a total of 7 plus total hours of learning. So, this was our first attempt on initiating academics pan India, and we were able to collaborate with so many different amazing faculty members throughout the world and pan India as well. And I think somewhere down in the past, we have just bifurcated from the academic discussion. Some things are going ahead against those kind of discussion. But in order to keep the spirit alive of academics, so we are going to continue such kind of series in the near future with different malignancies and completely a student-based approach, so that our students, once they get outside the shelf of their, super specialty life, they should know the academics. The rest of the things can come down later in the lifetime. But I think the academics is the main pillar of each and every doctor. The rest dynamics can be handled later on. And with this, I also thank, IAIO, Rudra, Roshni, and all the technical team, and obviously all the fantastic panelists, Veronica, Dr. Gaurav, Dr. Ethel, Dr. Arpita, who have been sport at 9:15 at night, and that too on a, Saturday night. So yeah, we will compensate for that. And till that time, I see you in the next conference, and goodbye from New Delhi Sir Gangaram Hospital, Department of Medical Oncology and Department of Urology and Oncology, Dr. Ashwin Balya.
Thank you, one and all. I think that brings us to the end. Good night. Good night.
Good night.
Thank you. So thank you both for having with us. Hope to see you for many more events. Thank you, sir.
Thank you, Roshni.